This conference will now be recorded.
All right, so let's talk about respiratory emergencies. So as we know, this is one of our biggest chief complaints we're going to come in contact with, other than that next being cardiac chest pain or acute coronary syndrome. But the thing is, though, is a lot of times respiratory goes hand in hand with cardiac issues as well. So we got to kind of pay attention to that kind of stuff. Just because it's a respiratory doesn't mean there's an underlying cardiac condition or is a cardiac condition causing the respiratory issue. And we'll get more into that here in a little bit. So obviously we're going to cover the EMS standard competencies. We're going to cover A&P a little bit, kind of do a quick review of the upper and lower airway anatomy stuff. Kind of go over signs and symptoms, management of the respiratory emergency, those that affect those too. From like upper airway for like stridor croup to lower airway like bronchitis, pneumonia, COPD type deals, asthmatics, moving through that. As well, we're going to be talking about epiglottitis. We see that more in our kids, spontaneous pneumos, pulmonary edema, asthma, and then going into more of the COPD, a little bit about environmental industrial exposure and toxic gases, pertussis, cystic fibrosis, pulmonary embolus, pneumonia, viral respiratory infections, and obviously obstructive and restrictive diseases. So there's a whole boatload of different things that we could come in contact with when we're seeing these in the field. So I'm going to try to put we're going to cover what this stuff says here. I'm hoping you guys all read the chapter for respiratory emergencies prior to this class, because I want you guys to ask the questions. But I'm going to try to put a lot more scenario-based stuff into this as well. But I think that's where we're going to hit a lot of learning, is what we're going to see in the field coming in contact with from patients on even from interfacility transports to 911 calls, both. And I want you guys to kind of have more of a wide range of what we're going to be seeing and how we're going to be treating these patients. And to keep in mind that some of our transport times could be 35 to 45 minutes, and in the cities could be 5. And do we have to make that long-term adjustment for these patients for these transports? So let's get into this. So obviously, let's talk about some of the introductory stuff. So dyspnea is difficulty breathing, right? So this is a complaint that you will encounter quite often. And then this could be the symptom of many different conditions that are out there, as we just covered in the previous slides. There's so many things that could cause this respiratory distress. The thing is we have to look at differential diagnosis, utilizing our tools of the trade that we have with us and our brains and our experiences, and say, hey, I think this is really what's going on. Let's start that treatment plan, and that's part of our differential diagnosis. So symptoms may vary from many different conditions, and several problems occurring at the same time may contribute to a patient's dyspnea, right? So they could be having a cardiac event, like an MI, but then also in turn is causing acute pulmonary edema with congestive heart failure, causing fluid buildup in the lungs. All comes in hand. So there could be one with another underlying condition that we need to think about treating as well. So we may have to treat one, then treat the next. Anaphylaxis being another one as well, because we think about anaphylaxis, we think about swelling, right? Stung by a bee, we start getting airway swelling. But on top of that, we're also getting constriction, bronchoconstriction, along with airway edema. So we have two different things we're fighting here, right? We have the excessive histamine release causing this reaction that we need to stop by giving epinephrine. But on top of that, we might have to also give like albuterol to treat those wheezes and that bronchoconstriction on top of it, right? So there could be some underlying things, or some things could be multiple different types of the process. So keep possible medical problems in your mind as you obtain a history and perform your physical assessment. We're going to treat our symptoms. We see symptoms, you need to treat them. Look for the underlying problems, and also this is also a buildup of anxiety as well. These patients are sick. So a little bit about A&P, kind of a quick review. And I know we covered it all in chapter 7, I believe it was, of human body, or 4. So the respiratory system consists of all the structures that contribute to the breathing process. The upper airway includes all anatomic airway structures above the level of the vocal cords. So if you look at the picture here, we have our vocal cords located here in the larynx. Anything above that is considered upper airway. Anything below that, from the trachea down to the carina, to the main bronchi, to the bronchioles, to the alveoli, all the way down on both sides to the lobes of the lung, that's lower airway issue. Make sure you understand that. That's the important pickup, because upper airway and lower airway can be treated differently. All right, especially when you start moving up in the paramedic stuff as well, depending on what medication will be given. All right, so the upper airway includes all those different airway structures above the level of the vocal cords. Where does the gas exchange happen?
In the alveoli?
That's right, the alveoli, right? So the gas exchange, or deoxygenated blood from the pulmonary circulation, releases carbon dioxide and picks up oxygen. This happens at the alveolar level, okay? If we have a deviation at the alveolar level, okay, that's where we're going to start seeing our problems. And what's one thing that we can utilize in the ambulance? I talk a lot about this.
End title.
Yeah, end title. And then who mentioned CPAP? Is that George?
Yes, it was.
Yeah. Okay. Awesome. Because I think it was Sean and George that talked on that one. I'm not sure. End title is our perfusion measurements, right? And CPAP helps support that. Okay, so we get that open lung to get into the alveoli to help promote that better gas exchange or push fluid out, depending on if it's pulmonary edema or if it's a bronchoconstriction. So everything works hand in hand. Pulmonary circulation begins at the right ventricle, right? So where the pulmonary artery branches into increasingly smaller vessels until it reaches the pulmonary capillary bed, which surrounds the alveoli and the terminal bronchioles. And I'll show you guys that in the next slide, right? So more circulation to the lung bases than there is to the lung apices. More circulation to the lung bases, okay? That's where a lot of that happens down below. Also, where our fluid starts building up if we have a patient in pulmonary edema, right? So let's look at the next slide here. As air is coming in, okay, coming into the bronchioles through the smooth muscle. Now, if a patient is in borderline failure, you want to get the paramedics on board right away if you can get one. We carry medications called magnesium sulfate, which everybody thinks is a cardiac med, is also a smooth muscle relaxant to help open up those smooth muscles to help the patient breathe better, right? So we carry that for respiratory purposes as well. But as it's coming in, number one here, deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and the arterioles, right? At that point in time, deoxygen, see the blue lines here, it comes into the alveoli. The gas exchange takes place at the capillaries covering the alveoli around it. So we have the carbon dioxide coming in, so the bad stuff's going to be exhaled out, as the good stuff, oxygen, 21%, on the inhalation comes in, right? And then it gets transported through our red blood cells. So oxygenated blood then carried from the lungs to the heart by the pulmonary veins and the venules. This is the only time where we're going to see oxygenated blood in a vein. Okay, the pulmonary veins and venules carry oxygenated blood. Other than that, it's always deoxygenated. That's the difference, right? So, real world stuff. If we have a patient who is COPD, okay, and we see a patient's pulse oximetry. Now, this is oxygenation. Pulse oximetry is 60%. Okay, you put them on end tidal CO2, and their end tidal is showing 20. They're breathing at 30 times a minute because remember, they're respiratory distress, and now they become tachycardic. What can we do to fix that problem? And what do you expect to see? Two questions here. What can we do to help fix that problem? And this is all basic level knowledge. And what do we expect to see on the waveform capnography? So medications. So Matt O'Connor, shark fin. Exactly.
We use albuterol.
Albuterol. And what's the other thing we can give, or device we could utilize? So CPAP.
CPAP.
You see CPAP fly through the comments. Perfect. That's what I want to see. Continuous positive airway pressure, CPAP, providing positive end expiratory pressure, PEEP. Okay? Utilizing PEEP with CPAP, inline nebulizers, pushing it down into the lungs, bronchodilation, better alveolar exchange, gas exchange, more oxygen to the system will in turn reduce respiratory drive, will then in turn drop your heart rate because now your heart's not pumping faster to get oxygen in. The patient becomes more stable, right? So Matt put down shark fin respiration or shark fin waveform. Why is that happening? And it's not just bronchoconstriction. Why would that be happening? Why do we see shark fin versus normal waveform? And yes, bronchoconstriction is part of it.
Hyperventilation.
That's going to happen. But what's going down? What's going down at the alveolar level that's causing that?
It's going to be poor gas exchange.
Okay, poor gas exchange and release, right?
Correct.
Let me ask you this: and I'm gonna give two different scenarios. Are the alveoli all releasing at the same time, or are they releasing at different times?
It's a super good question, and I would say different times.
That's correct. Yep, different. So right now, if everybody took a breath in and a breath out, we would every one of us in on this call, okay, unless someone is having difficulty breathing that I don't know about, you would have a normal plateau. Quick exhalation phase, plateaus off, get our end tidal, inhalation phase back down again. Okay. If we have any kind of bronchoconstriction and a reduction in the alveolar stuff, right? Okay. Hold on one second. Let me turn on this radio really quick. I'm back. I had a radio on in the office here. Just turned it off. All right. So if everybody took a breath in and out, normal plateau. If someone had COPD and they were having a COPD exacerbation or an asthmatic issue, okay, each alveoli will release at different times because of that constriction. We're going to get an uneven flow, and that's where that shark fin comes in, okay? So with that being said, bronchodilators will help fix this problem, but they also need steroids, something that you can't give. But AEMTs, EMTs can start that process by doing CPAP and inline nebulizers. And that's what's really going to help save this person right off the bat, is giving them that crutch. CPAP is like giving somebody D50 or D10 for a diabetic. It can turn someone around very quickly, very quickly. And that's what we're looking for, is to have that quick turnaround, right? CPAP, since it's been put into the field, okay, has reduced the number of intubations in the ERs. BiPAP has also done the same thing, but AEMTs can't administer it. That's just different inspiratory, expiratory pressures versus CPAP, which is just the expiratory only, right? So we're making a difference. We're making a difference quickly utilizing continuous positive airway pressure. All right. Any questions on this slide at all? No? Okay. Awesome.
No.
All right. So this figure here on the left illustrates a pulmonary circulation. The figure on the right compares respiratory systems of a child and an adult. Okay. Look at the size difference of the nasal cavity. right? The child's a little bit smaller. Obviously, they're growing. Okay. Look at the size of the airway itself, going down towards the trachea. Okay. So the oropharynx. You notice how it's a lot smaller? Everybody should be saying yes. Okay. It's smaller here. And on top of that, the trachea is not fully developed yet. So we're going to have a more narrow trachea, and the cartilaginous rings that go around it are not fully developed on a child, younger children, especially younger children. Okay. Because of that, hyperextension or hyperflexion of the neck can cause that airway to pinch off, especially in infants. Infants are the worst. That's why we always pat underneath the shoulders. Okay. So as the child gets older, then they become more solid and less chance of having a tracheal, I'm going to call it a collapse, but really it collapses on itself due to the hyperextension or hyperflexion. Right. So you got to look at the patient's age. And sometimes patting underneath the shoulders to keep that in an inline neutral position may have to happen. Right. So again, nothing new. This is all stuff that you guys have learned in your EMT classes. Nothing's different there. All right. So respiration has two processes that occur. All right. No worries, Jen. Inhalation, exhalation. So inspiration, expiration. So when you're doing lung sounds, you want to assess inspiration and expiration because they can sound different. You could have an inspiratory wheeze or a expiratory wheeze or both, right? Depending on the patient's status, right? Patients that have rails, right? You're going to hear that on the expiratory phase, not the inspiratory phase. As they're breathing out, you're going to hear that crackling, that watery type sound, that gurgling sound, right? So that's where you're going to see a difference. So when you do your narratives and you're documenting now, because you're ALS providers, document what you hear on the inspiration and the expiration, because that makes a difference. It makes a difference how we're going to treat our patients, right? So we have respiration, then we have ventilation, the process of moving air in and out of the lungs. Oxygen entering the alveoli passes through the tiny passages into the alveolar wall and into the capillaries. Now we're starting to oxygenate. And I'm going to keep repeating myself over and over and over again. We're going to measure oxygen through SpO2. We're going to measure perfusion and ventilation through end tidal monitoring. So the heart pumps oxygenated blood throughout the body, right? And we'll get into cardiac cycle in the next class. So the heart pumps oxygenated blood throughout the body, then carbon dioxide then returns to the lungs in the blood that circulates through and around the alveolar air spaces. Carbon dioxide then diffuses back into the alveoli and travels out through the upper airway during exhalation. Carbon dioxide is exchanged for oxygen. So remember, the good stuff comes in, it goes round and round, bad stuff comes out, exhale back through, and that's what we're going to have to monitor. So the figures you see here. So the first, the figure shows the exchange of oxygen and carbon dioxide during respiration. All right. So oxygen then passes from the blood through the capillaries into the tissue cell, as you're seeing here. Okay. These are blood cells. Okay, these are red blood cells. These are the capillaries here. Oxygen nutrients are then being traveled. They pass through, right, into the tissue cells. Then we off gas back out the bad stuff. That's our carbon dioxide and waste, right? So again, good stuff comes in on the red lines, right? The bad stuff comes out on the blue lines through the alveoli, right? And we'll get more into alveolar issues later on in this lecture. So in the lungs, oxygen is picked up by the blood and carbon dioxide is then given off, and that's how we get our measurements. So inspiration is the stimulus to breathe, which comes from the respiratory center in the medulla, right? So involuntary control of breathing originates at the brainstem. So impulses for the autonomic breathing, or automatic breathing, I should say, can be overridden to a point by voluntary control, right? So we can control our breathing, right? We can hold our breath, but eventually our body's going to trigger our breath at some point in time, but we can voluntarily take over our breathing. Everybody in the room right now or in the class could easily hyperventilate themselves. But with that reduction of carbon dioxide being expelled, which means you're retaining more, right? What's going to happen? Reduction of carbon dioxide being exhaled through hyperventilation, what will happen to your body?
You're gonna have alkalosis.
And you're going to pass out, right? You become acidotic, right? Because we have hyperventilation. Eventually, they're going to pass out. So one of the things I teach in my water rescue classes is types of drownings. And one of the drownings that we talk about is what they call shallow water blackout or hyperventilation. Because they're, in theory, if you hyperventilate and you keep in all that carbon dioxide and train your body to hold, you can hold your breath longer. The problem is that our body doesn't like that, throws off our pH, and causes a syncopal episode. The next thing you know, they drown, right? So again, we can control this to a point, right, by voluntary control, but eventually our brain will then take over and it will trigger, excuse me, then it will trigger a response to breathe and control it better. So motor nerves of respiration are the phrenic and intercostal nerves. So during inspiration, the diaphragm and the intercostal muscles contract. The thorax then enlarges and intrapulmonary pressures fall below atmospheric pressure. Because of that, air is now pulled in and fills the lungs, right? When air pressure outside the thorax equals pressure inside the thorax, inhalation will stop. So our normal inspiratory reserve volume is about 3,000 mLs in an adult male and 2,300 mLs in an adult female. Right, these are numbers you might want to memorize. You're probably going to see these on a quiz, which gets released tonight at 10 o'clock. All right, expiration. So as the chest expands, stretch receptors in the chest wall and the bronchioles send a signal to the Upsnik center via the vagus nerve to inhibit the inspiratory center, and expiration then occurs. What cranial nerve is the vagus nerve? What cranial nerve is the vagus nerve? Who's looking it up on Google right now? Anybody else want to throw some ideas out? Very important to understand the 12 cranial nerves that we have and what they do.
11.
I got 11, I got 8.
10.
10, right? So the 10 cranial nerves. That's our vagus nerve. What happens when we stimulate the vagus nerve? What happens if we stimulate it?
You go bradycardic
Yeah,
and oftentimes pass out.
yeah, exactly. So this can be stimulated even just by bearing down, right? It can also be done by quick excitement. A lot of things can cause that vagus nerve to be stimulated. Even putting in certain airways can stimulate vagus nerve response, including King Airways. If you trigger the vagus nerve response, you can drop the heart rate down. right? So it can definitely be useful to have an understanding of how that nerve actually works. All right. So again, so vagus nerve inhibit the inspiratory center and expiration occurs. Then you have the Herring-Breyer reflex, right, which is an inflation reflex, which is triggered to prevent the overinflation of the lung. So what happens is the pulmonary stretch receptors present at the wall of the bronchioles of the airways, and they respond to excessive stretching of the lung during a large inspiration. So we have that Herring-Breyer reflex. So this will prevent overexpansion of the lungs. Normal expiratory reserve volume is about 1,200 mLs, and then the expiration lasts twice as long as the inspiration, right? So we breathe in fast, expiration takes a little bit longer. That's when we start talking about our inspiratory-expiratory ratio, which is our IE ratio, right? We'll cover more of that a little bit later on. The expiratory phase is prolonged in a patient with asthma, and the expiratory phase is short in a patient with tachypnea, right? So asthmatics have a longer or a prolonged expiratory phase because they can't push that air out of the lungs. It's an exhalation issue with a built-up of massive mucus within the bronchioles, right? That's what asthmatics are. We got to open that stuff up with bronchodilators. That's why patients who are asthmatics carry an MDI rescue inhaler because albuterol being a bronchodilator, right? But a patient who's tachypnic or hyperventilating, they're going to have a shorter expiratory phase. Therefore, IE ratio changes from inspiratory to expiratory for the ratio, and then we need to control that. If not, hyperventilation and taking in all that acid or the carbon dioxide will not allow our bodies to function and meet homeostasis for very long before someone passes out. And we need to control this. So what can we do to control inadequate breathing? Either breathing too slow or breathing too fast.
Bag them.
Bag them. I see Justin put down BVM in the chat box. Exactly. Right? So we fix the problem by bagging them, right? So we can help fix that IE ratio, and then in turn, we'll reduce our respiratory rate, again, reducing our heart rate, increasing our end tidal back to a homeostasis level, right? All this plays into one big game. All right, so pathophysiology, okay? Adequate ventilation, diffusion, and perfusion must occur for the body to receive nutrients and oxygen, right? Air has to come in, air has to go back out. We have to have open lungs, good gas exchange. With all this happening, we have good perfusion, right? There's no blockages, there's no stops, there's no shock, there's nothing going on, right? Good ventilation. If we have that reduction and the patient goes into shock, or the reduction with blockage due to COPD or asthma, anaphylaxis, things like that, now our body can no longer adequately ventilate, and therefore we'll start seeing changes in the system, right? So some complications interfering with oxygen intake would be a foreign body airway obstruction in the upper airway, trauma, or any kind of inflammation, right? Lower airway obstruction would be trauma, obstructive lung disease like pneumonia, airway edema, a smooth muscle spasm, mucus accumulation, or even number 3, we start talking about chest wall impairment like trauma, hemothorax, pneumothorax, pleural effusion, pleural inflammation, neuromuscular disease. We start thinking about cystic fibrosis, things like that, or neurological problems like brainstem malfunction. So you can see that in trauma as well, or significant like TBIs, stroke or other medical neurological conditions, trauma or neuromuscular disease. All these things can cause a deviation of normal respiratory patterns. By rapidly assessing the patient, providing necessary interventions, problems associated with oxygenation and ventilation can be minimized or avoided. So if you look in your books, table 17.3 lists the key signs and symptoms to help you recognize and differentiate between different respiratory complaints. Know the different complaints and how to differentiate. But anybody that has any sign of difficulty breathing, they should be on nasal cannula end tidal and pulse oximetry and a cardiac monitor, right? Anybody that has a respiratory problem should be, I said will be, shall be receiving a 12 lead EKG, not a 4 lead, but a 12. Because remember, there could be an underlying condition causing that respiratory distress. You cannot pick up a STEMI on just a 4 lead, okay? Because you can't see the whole picture. You need the big picture. A STEMI can cause shortness of breath. Shortness of breath, pulmonary edema can cause a STEMI or be caused from a heart attack. So you've got to try to utilize all your tools. Look at that big picture. Right. Let's talk a little bit about gas exchange interface. So the alveoli are made up of two types of cells. We have type 1, which is pneumocytes, which are almost empty, allowing for better gas exchange, right? And we have type 2, which make new type 1 cells and produce surfactant. What is surfactant? It's on the screen. Lubricant, right? Lubrication. So surfactant, as you can see in a couple bullets down, reduces surface tension of the alveoli, making it easier for them to expand, right? The alveoli function best when partially inflated. So we have to be able to have that elasticity, that expansion, and surfactant has that, right? Making it easier. So after a foreign material gets into the terminal bronchioles and alveoli, it typically never comes back out, right? So collapsed fluid-filled or pus-filled alveoli do not participate in that gas exchange, all right? And they can be pus or fluid-filled based on CHF or asthmatics or bronchitis, things like that have a buildup of extra mucus, right? If we have a alveolar collapse, what is that called? What is the name for that? If you have alveolar collapse, what is that called? It does start with an A. AT.
Atelecticus, something or
Yeah,
other.
atelectasis. That's correct, yes. Right. And I can almost guarantee you're going to see that on a national exam. So make sure you guys understand the word atelectasis is alveolar collapse, which can happen from the lack of surfactant. And therefore, collapsing will make it so you can't have proper gas exchange, therefore causes difficulty breathing. Right. So other conditions related to ventilation perfusion of both can prevent oxygen from reaching the bloodstream. Right. So pulmonary capillaries now are narrow and normally allow red blood cells to pass through only in a single file. So people with chronic lung disease or chronic hypoxia generate a surplus of red blood cells over time, making blood thicker. With this, it places strain on the right side of the heart, and you'll start having right-sided heart failure because of the chronic lung disease, or what they call cor pulmonale. All right, a little bit about carbon dioxide, retention and hypoxic drive. So when would you see a patient that retains carbon dioxide? What kind of patients retain carbon dioxide? Right? You're seeing patients with COPD, exactly. So if a patient has a pulse oximetry reading of 90% and they have COPD, is that okay?
Yes, that's probably where they live.
It's not a bad thing, but like Justin just said, great answer. Ask them what their normal is. If they have COPD and they're normally at 98% and they're sitting at 90, now we need to fix that. What is normal for the patient? That's a great answer, Justin. What is normal for the patient? Right? You have to have good communication with this, okay? So the level of carbon dioxide in the arterial blood can rise for many reasons, right? So there are various types of lung disease that may impair the exhalation process. We just brought one up, COPD. So the body may produce too much carbon dioxide temporarily or chronically, depending on the situation. If the arterial carbon dioxide levels rise slowly to an abnormally high level and remain there, the respiratory centers may work less efficiently. So failure of those centers to respond normally to a rise in arterial levels of carbon dioxide is a result of a chronic carbon dioxide retention. If you have a patient with COPD with chronic carbon dioxide retention, what would you expect their chest to look like?
Barrel chest.
Barrel chest, exactly. It's also what we call increased AP diameter of the chest. Okay, so they'll have an increased AP diameter, barrel chest, because of that retention and the buildup of those muscles as well. So we start seeing that barrel chest. Now, with a hypoxic drive, conditions where the brain gradually accommodates high levels of carbon dioxide and uses a backup system to control breathing based on low levels of oxygen rather than high levels of carbon dioxide. That's what our hypoxic drive does. This stimulus to breathe is detection of low blood oxygen levels. So if the arterial level of oxygen is increased, there is less stimulus to breathe, right? If we have our SpO2 of 100%, are we going to breathe 40 times a minute?
Not necessarily.
No, not necessarily. But that's the normal hypoxic drive, right? Now we start talking about conditions, and that can make the change. Giving too much oxygen to these patients may actually depress or stop respirations. Never withhold oxygen from a patient who needs it, but do we need to give them 15 liters non-rebreather every single time because the book says to? Right? Do we need to do that every single time? No. We're ALS providers now, right? We're allowed to think, okay? We're allowed to think and treat our patients. Can they maintain through a nasal cannula? Yes or no? Again, depends on the presentation. Patients that have shallow respirations, what is the first thing as an EMT that we always did? Breathing 30 times a minute, shallow respirations. Everybody threw them on a ventilate, or they threw them on a non-rebreather and said, let's go. So non-rebreather, 15 liters per minute, and then they move forward, right? So keeping that kind of stuff in mind. But again, never withhold oxygen for a patient that actually needs it. Right. Hypoventilation. Excess carbon dioxide in the blood and respiratory acidosis, right? So patients breathing too low, we have an increase in end tidal causing respiratory acidosis. So this can occur, or back a few minutes here, a few steps. So when the lungs fail to work properly, carbon dioxide accumulates within the blood, right? For hypoventilation. Combines with water to form bicarbonate ions and hydrogen ions, also known as carbonic acid, resulting in respiratory acidosis, which we don't want to happen. So we're going to have a decrease in pH, an increase in end tidal, And because of this, we have that direct correlation with our acid-base balance, looking at pH and respiratory. Right? So acidosis can occur if hypoventilation is not recognized. So where would you find a patient that potentially could be in respiratory acidosis? Give me two scenarios really quick on top of your head that respiratory acidosis may kick in.
Drug overdose.
Drug overdose being one, right? And how about,
Diabetes?
well, diabetes, you'll have the Kussmaul respiration, so it might be a little faster, right, initially, and that will change over time. Or change Stokes to that. I got Justin saying brain bleed. How about cardiac arrest? Because they're not breathing at all, right? So what is the first thing that we see in a patient who's in cardiac arrest and we get pulses back? What's the first thing that happens? What does that end tidal do? Goes up, right? So this is a patient who's in cardiac arrest. So Justin, you're right, it is dropping down. But if they get a pulse back, we see that big spike in end tidal, all right? Because now they're breathing slow on their own and they're finally able to release gases. So they're very, very, very acidotic, which is another reason why they've always, in past ACLS, they talk about giving sodium bicarb to help neutralize that acidity and help that the bicarb system get back into a normal range. So we have a patient that goes into respiratory acidosis. So carbon dioxide levels increase and the pH decreases. And because of the causes of hypoventilation, it could be like an impaired lung function or an impaired mechanics of the breathing itself. Excuse me. Obesity hypoventilation syndrome, or what they call Pickwickian syndrome, is a respiratory compromise related to morbid obesity. So we have a patient who weighs, let's say, 450 pounds, and you lie him flat, what's going to happen? Yeah, they can't breathe. It's called positional asphyxia. Yeah, they suffocate, struggle, because there's so much weight on the patient's chest, their lungs cannot expand and they cannot inhalation. They can't, my God, I can't even think today. They cannot inhale or exhale, inhalation, exhalation, and provide a good homeostasis. We got to sit them back up. So other things we would find for impaired neuromuscular apparatus would be a serious injury to the spinal cord. Otherwise would be like Guillain-Barré syndrome, amyotrophic lateral sclerosis or ALS, Lou Gehrig's disease, botulism caused by the bacterium, reduced respiratory drive like acute opiate narcotic overdose of heroin, fentanyl, any one of the opiates. Opiates or opioids, I should say, either one. Intoxication with alcohol, narcotics, and a host of other drugs and toxins, head injury, hypoxic drive, and asphyxia. So all these different things can cause that hypoventilation, right? So we got to kind of pay attention for that. If we see a patient that's only breathing 6 times a minute, 8 times a minute, then maybe we need to ventilate. Stop putting just straight oxygen on these patients, like they teach us to do in a lot of our, EMT books, even first responder, things like that. They go, oh yeah, well, if they're breathing 10 times a minute, just throw them on non-rebreather nasal cannula or non-rebreather at 15 liters a minute. No, they need help ventilating, right? If they're breathing normal and their oxygen levels are low, there's nothing wrong with putting oxygen on a nasal cannula, non-rebreather, depending on what they need. But if their respiratory status has changed, okay, and now they're breathing too fast, too slow, they're labored, okay, that's when they need that respiratory support, not just the oxygenation, but that ventilation to help perfusion. And that's where you start breaking in the BVMs and or CPAP, depending on what you have for a patient in front of you based on symptoms. All right. So let's talk about hyperventilation, and then we'll take 10 minutes. By that time, it'll be 7 o'clock. We'll take 10 minutes, come back, and we'll keep plugging forward. So hyperventilation, which is an arterial carbon dioxide falls below normal, okay? So we're going to see low end tidal readings because the patient's hyperventilating, may be an indicator of a life-threatening illness. If you're breathing fast, it's the body's way to compensate for acidosis. You're trying to blow off the gases, right? So the buildup of excess acid in the blood or body tissues will cause that hyperventilation, which in turn will lower the carbon dioxide, which helps to compensate for other acids that are there. So tachypnea without a physiologic demand for increased oxygen causes respiratory alkalosis, right? So some causes and symptoms of hyperventilation syndrome, or they call it panic attacks, right, would be anxiety, dizziness, numbness, tingling of the hands and feet that can lead to carpal pedal spasms, or a sense of dyspnea. We want to make sure we measure these things on our assessments as well, looking at dyspnea based on how many words they can speak before their next breath, and that needs to be documented in your reports. Can a body's response to illness and a buildup of acids? It could be that as well, or hyperventilation syndrome as well would occur in the absence of other physical problems. So these are common during the psychological stress, right? But there's a lot of other things that could cause hyperventilation as well. And we'll talk about later on, but dyspnea and hyperventilation would be like PEs and things like that. All right, so we'll get more in tune with this when we get back from our break. So let's come back at 7 o'clock, and then we'll continue from there.
This conference will now be recorded.
All right, so let's go over some causes of dyspnea. So shortness of breath or difficulty breathing is dyspnea. So if there's a problem, if the problem is severe and the brain is deprived of oxygen, the patient may not be alert enough to report shortness of breath. So we'll have to pick up on that. With that being said, altered mental status is also a sign of hypoxia of the brain. So if we see altered mental status, could they be hypoxic? So, excuse me, let's look at end-tidal CO2 along with SpO2, and then looking at our rates, things like that, to see where we kind of sit. What is our baseline going to be? So patients often experience breathing difficulty or hypoxia with pulmonary edema, hay fever, pleural effusion, an obstruction of the airway, flail segment or rib fractures, cystic fibrosis, hyperventilation syndrome, prolonged seizures, neuromuscular disease such as multiple sclerosis or muscular dystrophy, environmental or industrial exposure to a toxic gas, carbon monoxide poisoning, and drug overdose. So there's a whole boatload of different reasons why the patient could be hypoxic. So one or more of these situations most likely exists. So a gas exchange between the alveoli and pulmonary circulation is obstructed by fluid in the lung, infection, or atelectasis, or collapsed alveoli. So like pneumonia being an infection in the lung. Remember that pneumonia is lobe specific, not just all over, but it could be all over depending on how severe the pneumonia is. So you listen to lung sounds, make sure you're listening to every lobe as you're listening, and see if you can hear any kind of bronchi noted or mucus type exchange. If the alveoli are damaged and cannot transport gases properly, then we start getting different changes in end tidal, and the patient becomes more hypoxic because now we're not oxygenating the cells. Start seeing the same signs of shock. So air passages are obstructed by muscle spasms, mucus, or weakened airway walls. Blood flow to the lungs are obstructed by blood clots. So there's our pulmonary edema, or the pleural space is filled with air or excess fluid, right? So we could have pleural effusions, we could have pulmonary edema, we could have pulmonary embolus, we could have cardiac event like an MI causing this as well. So we have to do all of our different testing. We have a lot of tools to our trade, right? So we have 12-lead cardiac monitoring. We have blood vital signs of blood pressure, end tidal, pulse oximetry, stethoscopes to assess lung sounds. There's so many different things that are out there that we can utilize and tools at our disposal to utilize differential diagnosis to come up with a treatment plan and a diagnosis of what you think clinically is wrong with your patient. And we can do all that by utilizing our tools that we have and also past experiences as well. So a patient with dyspnea may also report air hunger. I can't catch my breath. I can't breathe. They'll start looking like they're hungry for more air. They'll speak in like 1 to 2 word dyspnea, so they can only get 1 to 2 words out before their next breath. Right? Other dyspnea is a common complaint in patients with cardiopulmonary disease. And heart failure is the cause of breathlessness. If they can't breathe, they cannot catch their breath, take a good listen to their lungs. Most likely they're probably going to be in a pulmonary edema or some kind of heart failure. Okay? We want to be able to pick up on that well, and also getting a good set of vital signs. Severe pain can also cause the patient to experience rapid, shallow breathing without any pulmonary dysfunction, right? So pain can cause tachypnea. So what can we do to reduce pain? Okay, breathing deeply may also cause pain as well because it expands the chest wall for deep breathing. So when assessing a patient for complaints of dyspnea, ask about the chest pain. What does it feel like? Is it sharp, dull? Is it a pressure? Is it reproducible, pushing on the chest? Right? If you can reproduce the pain, most likely, not guaranteed, but most likely, it's going to be muscular in nature versus actual cardiac in nature. Right? Other things you can look for too are Levine sign, right? The clenched fist versus open hand across the chest. So you want to make sure you're doing a good cardiac assessment with a respiratory assessment, depending on the patient's clinical presentation. Right? So upper and lower airway infections. The upper and lower airway infection is an infectious disease that may affect all parts of the airway. May also cause dyspnea by obstructing airflow in larger airways, or may impair exchange of gases between the alveoli and the capillaries, and that you would see with pneumonia. Acute pulmonary edema is an accumulation of fluid in the lungs. If we have fluid in the lungs, we're going to have a decreased gas exchange and severe dyspnea. But you have to listen to lung sounds. Very, very important. We're going to cover that here in a second. All right. Severe myocardial damage caused by an acute or chronic problem results in a reduced contractile force of the myocardium. If the left side of the heart cannot remove blood from the lungs as fast as the right side delivers it, we start seeing a backup of fluid into the lung space itself, and that's when we start getting our acute pulmonary edema. Fluid starts collecting in the alveoli and the lung tissue, and this may develop very quickly. Not all patients with pulmonary edema have heart disease, though. Other causes from this could be a poisoning from smoke or toxic chemical fumes, traumatic injuries to the chest, exposure to high altitudes. What else can cause significant water in the lungs or fluids? Yep, drowning. Absolutely. Drowning it is. And Maine actually has a pretty decent protocol for drownings now. So take a look at it if you haven't seen it before. It's pretty good. Right? Patients with pulmonary edema that are cardiogenic in origin may present with signs and symptoms of a cardiac emergency. So patients with non-cardiogenic pulmonary edema tend to have a history of associated factors, right? Like hypoxic episodes, shock, chest trauma, recent acute inhalation of a toxic gas or particles, right? Superheated gases cause airway swelling and cause edema, right? Recent ascent to a high altitude without acclimatizing first, right? All patients with pulmonary edema may present with dyspnea, fatigue, orthopnea, reduced exercise capacity, and then pulmonary crackles, which we used to call rales. I still use rales. I'm an old school guy, right? But pulmonary crackles in the bases of the lungs. Crackles and bronchi are two different sounds, right? Become very familiar with this, okay? Very familiar with lung sounds. And I tell this to all my students, the best way to do it is go out and buy a stethoscope, put it onto the speakers of your computer, listening to lung sounds through your computer on your speakers, through your stethoscope. So that way there you can hear what it sounds like through a scope in the back of an ambulance or on a patient, all right? Or just go spend time in a nursing home, listen to everybody's lungs. You'll hear every lung sound known to man. So COPD, which all of us being in this field have had at least one COPD exacerbation, call them short, all right? This is a common lung condition, which is a slow process of dilation and disruption of the airways and the alveoli. If we have a disruption of the alveoli, slow process, is where we're going to start seeing our Sharkin waveform. COPD is an umbrella term used to describe a few lung diseases, including emphysema and chronic bronchitis. One of the most common causes is cigarette smoking. Obstruction occurs in the bronchioles, where the cilia are unable to remove excess mucus, creating a buildup within the airway, or I should say the bronchioles, therefore causing that restriction in airflow and then the shortness of breath. Chronic bronchitis is a result from overgrowth of the airway mucus glands and excess secretion of mucus as well, blocking the airway. So patients have a chronic productive cough for at least 3 months per year or 2 or more consecutive years as chronic bronchitis. So one of the questions you want to ask them is, another question you want to ask is, do you have a dry cough? Or are you producing any mucus? And if so, what color is it? All right. To find out if it truly is like a bronchitis or is there an infection of some sort going on. All right. Pneumonia develops when the passages are persistently obstructed. So repeated episodes can lead to COPD for repeated episodes of pneumonia. Rib fractures, okay, patients that don't use, my goodness, I can't think of the name of it, spirometers, to be able to actually test their lung capacity and work their lungs, right? If they have those shallow respirations for long periods of time, that can develop pneumonia. Or emphysema, which is the most common form of COPD. These are the ones that we have our patients that increase AP diameter and that dry cough, which is characterized by destruction of the alveolar walls related to destruction of the pulmonary surfactant. Therefore, we start having alveolar collapse, or they start, we'll talk about blebs in a little bit. Another one would be large holes, which are left in the lungs that resemble air pockets or cavities. This is an irreversible condition. So with that being said, these patients here might live on oxygen only at night, during the day, 24 hours a day. They have nebulizers they receive at home, help them breathe. And these are the patients that get those exacerbations that can cause significant respiratory compromise. So most patients with COPD have elements of chronic bronchitis and emphysema. So have a history of recurring lung problems, like are long-term smokers, consistently produce sputum, they have a chronic cough, have difficulty expelling air from their lungs, experience long expiration phases and wheezing. Patients with acute COPD will complain of shortness of breath with gradually increasing symptoms over a period of days. They exhale through pursed lips, right? complain of tightness in the chest and constant fatigue. They also have a chest with a barrel-like appearance, right? That's increased AP diameter. Why are they pursing their lips? Why do they do that?
To mimic CPAP?
Right, to mimic CPAP, they're creating PEEP. So if anybody ever wanted to try that at home, take a deep breath with your mouth wide open and then exhale. And do the same thing with pursed lips. You're going to see the fact that your lungs stay open for a longer period of time. So when I was at work a couple weeks ago, I actually did a demonstration of this as well with a ventilator and a glove, and I showed people the difference with PEEP being high versus no PEEP at all. Remember that our vocal cords create PEEP as well. So if a patient loses function of their vocal cords, they can no longer provide PEEP in their airway. Right. So this is why patients that have severe airway burns, near drowning or drowning episodes, these patients here need to be intubated sooner than later as well, as long as they have airway burns or superheated gases getting into the airways, causing significant airway swelling as well. So this figure here shows you how repeated episodes of irritation and inflammation in the alveoli result in obstruction. As you can see the normal lung over here. Then you start seeing the inflamed lung. This becomes obstructed here when you start seeing the dilated alveolus. So they start popping and becoming bigger. Air is getting trapped in the alveoli, causing them to dilate. So as you can see, the normal bronchial coming in the alveoli here is wide open. Once we start seeing inflammation and infection with mucus, we start trapping air. And once it's completely blocked off, complete obstruction, with an infection causing swelling, at that point in time, we start seeing dilated alveoli, and then they're eventually going to collapse. There's not going to be anything left to them. So that's the infection that you're seeing, followed by a mucus plug, which is right here. This is why they need bronchodilators to open this stuff up to help them breathe better. Asthma is an acute spasm of the bronchioles, right? As you can see, looking here at the bronchiole, this is a normal bronchiole. Then we have mucus obstructing the bronchiole here. These are patients that become asthmatic, right? They have mucus production and significant edema. That's why they receive nebulizers and/or they have an MDI inhaler to help bronchodilate, making the bronchioles bigger to offer better air passage. So status asthmaticus is a severe prolonged attack, which cannot be resolved with conventional treatments. So that's your MDI inhalers and things like that, okay? What these patients truly need, the status asthmaticus patients, are more steroids, epinephrine to open up the airways, to maybe potential for epi drips to be given for paramedics, or they may have to be intubated until the status asthmaticus is cleared. All right, so wheezing is heard when asthma patients exhale. So it's when you have the audible wheezing, you hear it walking through the door, or they'll have the expiratory wheeze. This results from an allergic reaction, exercise, severe emotional stress, or a respiratory infection. Anaphylactic reactions are severe allergic reactions characterized by airway swelling, dilation of the blood vessels all over the body, and sometimes called anaphylactic shock. This can cause respiratory distress severe enough to lead to a coma or death. So this may be associated with widespread hives or what they call urticaria, itching, signs of shock, and signs and symptoms similar to those of asthma. Right? So look for that widespread urticaria, the hives. Ask them if they were stung or bit, if they know about it. Ask them if they had any changes. But they're significantly anaphylactic. Before we start asking questions, we need to get epi on board. Most reactions occur within 30 minutes of the exposure to an allergen, whether it be a bee sting, a flower, a type of food, whatever it may be. Usually within 30 minutes, they can go full-blown anaphylaxis where you'll start seeing reactions. All right, a spontaneous pneumothorax is an accumulation of air in the pleural space, which may be partial or complete. So if you look at the photo here, okay, the lung on the left-hand side, all right, has the pneumo. As you can see, the lung has shrunk down. Airspace coming through here, air is coming in. You have increased pleural space and increased pressures to the walls. Because of that, this one here is actually a wound site, so it's a stab wound or a gunshot wound to the lung, puncturing through and puncturing the lung, causing it to deflate. Remember that our lungs run on a negative pressure system. This also may be caused by a medical condition referred to as a spontaneous pneumo, where this may occur in patients with certain chronic lung infections who are young and were born with a weak area of the lung, who have emphysema, and who have asthma. What population is higher risk for a spontaneous pneumothorax?
Neonates?
Try a different one.
Geriatrics?
No, not the geriatrics.
Peds?
Tall and skinny.
Tall and skinny. Yep,
Oh,
Yeah, tall, skinny males.
yep. Tall, thin, athletic males are at higher risk. Interesting, right? So patients become acutely dyspneic and complain of a pleuritic chest pain, right? Acutely dyspneic. They can't breathe. Remember, you don't see tracheal deviation. That's a late sign, okay? But the pleuritic chest pain, so when you push on the chest, it hurts even more. Sharp stabbing pain on the one side that's decreased. Worse during breathing or with certain movements of the chest wall. It may present with subcutaneous emphysema. What is that?
Air under the skin.
Yeah, air into the skin. And it'll feel like what when you push on it?
Rice Krispies.
Yeah, there you go. Rice Krispies. Yeah, air trapped under the skin. So if you have a patient with subcutaneous emphysema, make sure you get good lung sounds. You probably have a pneumothorax, right? And how do we fix the pneumothorax?
Needle decomp.
Right. Need ALS. Paramedic on board. Call for a medic. Right? Please do not do one on your own. And if they have this, most likely 99% chance they're going to be getting a chest tube. Only about more than 100% chance they're going to get a chest tube at the ER.
We ran this call exactly verbatim last night.
Really? Did
Yeah,
they get a chest tube?
they did when they got to the hospital.
Yep. Did you guys at the medic level? You guys do a decompression?
They did.
Nice.
It's always fun to watch.
Especially when they hear the air release.
Yep.
I don't know why the phone's ringing. There we go. All right. So patients may be present with subcutaneous emphysema, and breath sounds are also absent or decreased on the affected side. So minor problems, you'd see pale, patient will be pale, diaphoretic, tachypnic. The severe findings would be altered mental status, cyanosis, tachycardia, unilateral decreased breath sounds, local hypersonance to percussion. So to do percussion, I'm not talking about percussion therapy that you would utilize for cystic fibrosis, but what you do is you take your stethoscope, put it on their back where their lungs are located, and you just tap like this. You can hear my sound here. You just tap on their lungs and you look for that sound, whether it be like a hollow sound or a thud. Right, that's a hypersonus percussion we're going to check for. Late sign will be tracheal deviation, also subcutaneous emphysema. So the pleural effusion, which is a collection of fluid outside the lung or on both sides of the chest. Fluid in here may be from irritation, infection, or heart failure or cancer. With that, patients often report sudden
He's
dyspnea.
gonna get 4. And I was like, do you have any? They go, we have 1 left. I was like, I'll take it. I call
It
it
should be
so,
considered in patients with lung cancer and or shortness of breath.
I'm just gonna get 1 for you, 1 for me, and then 1 butts, and then 1 each for work.
You also find decreased breath sounds over the chest, where fluid has been moved the lung away from the chest wall itself. Feel the decreased breath sounds. Patients usually feel better when they sit upright because that fluid tends to drain down, helps them breathe a little bit better. And then definitive treatment obviously is fluid removal from pleural effusion. You may see a lot of if you do transfer work at all, you may see a lot of patients with pleural effusions be transferred to more like larger pulmonary centers. I've taken a lot of pleural effusion patients over my time doing interfacility work. All right, hold on 1 second here. All right, I'm back. All right. So a PE, something that you really should be picking up on, and in the field. And there's a lot of different signs and symptoms that can indicate this as well. We'll go over those here in a second. So pulmonary embolus or embolism is a blood clot or a thrombus within the pulmonary circulation, usually formed in a vein in the leg or a deep vein thrombosis or DVT or the pelvis. And then it breaks off, circulates through the venous system, and moves through the right side of the heart into the pulmonary artery. It then decreases or completely blocks the blood flow, where there's no exchange of oxygen or carbon dioxide occurs in the areas of the blocked blood flow. There's no exchange happening. This causes ventilation perfusion mismatch, or the VQ mismatch. They talk about it. We need to pick up on PEs quickly. Okay, I've had patients literally die in the back of the ambulance because there's nothing you can do for a PE in the back of an ambulance, no matter what level you are, to get that clot removed. They need to get thrombolytics and or potential surgical removal. There's nothing we can do in the back of an ambulance to help with that. Right? These patients need to get to the hospital quickly. So this may also occur as well as a result of damage to the lining of the vessels, hypocoagulability, slow blood flow in the lower extremity. And some of the risk factors behind this would be immobilized legs following a surgery or a fracture. So any kind of surgery or even recent surgery can cause this as well. They can have a clot that frees up and goes through the system. Pregnancy, right? Especially after delivery. Previous pulmonary emboluses. First degree relative who has had pulmonary embolus before. Obesity, oral contraceptives, smoking, infection, cancer, sickle cell anemia, prolonged inactivity, patients that are bedridden, right? We want to make sure we pick up on the lifestyle that patients live as well. And then looking at our signs and symptoms, which would be dyspnea, tachycardia, tachypnea, hypoxia, cyanosis, acute chest pain, hemoptysis, so vomiting blood, as well as syncopal episodes, looking like it's anxiety. And the thing is, you could be 19 years old and have a PE, or 99 years old. Doesn't matter, right? Don't brush things off because it's a 23-year-old who looks like they have anxiety attacks. right? Do more digging. Look at the signs and symptoms, okay? Anxiety attacks don't have that that tachypnea, tachycardia stuff, okay? Not as much. They don't have that acute chest pain with syncopal episodes, right? Look past just the anxiety and see what else is going on. Get that medical history. Are they taking birth control, right? Do they take a daily aspirin because they're on birth control? Birth control can be one of the big causes of PEs. Have they had any long distance travel, whether by air or by ground, right? The inability of moving legs can start having calf pain, which could free up. So ask the patient, have you had any calf pain at all, right? Dig deep into your assessment to find out what potentially could be going wrong, right? Pulmonary emboluses are critical. Let me go back one slide here. No, that's not the right way. Other things to look for with this as well, okay? Put them on end tidal. Patients that have that might potentially have a PE or a PE moving closer to the lungs, causing a full pulmonary embolus, right, will have normal waveform capnography with normal readings. If they have a sudden change in end tidal numbers to decrease, like around 18 to 20, there's a potential that they could have a pulmonary embolus. Okay, it's that sudden decrease of being normal, 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 and then dropping quickly. So patients you may suspect pulmonary embolus, once again, put them on end tidal, right? And watch for those changes. Obstruction of the airway, very simple stuff, right? Patient with dyspnea may have mechanical obstruction, something could be blocking it, whether it be a food or a foreign body airway, or the patient's unresponsive, lying on their back, it could be their tongue occluding it. Other potentials could be vomitus as well, or improper positioning of the head so the tongue does block the airway. So always consider upper airway obstruction from a foreign body first in patients who are eating just before they became short of breath. Also, find a way to keep their airway open, whether that be utilizing an NPA or an OPA if they don't have a gag reflex, to maintain and protect any potential airway compromise. What was that? All right. Well, somebody had something for me. Right. So some environmental industrial exposure now. So potentially toxic substances can be inhaled. You know what you do for work. Pesticides, cleaning solutions, chemicals, chlorine, carbon monoxide, and other gases. Chemicals such as ammonia and chlorine bleach can create a hazardous byproduct as well. Okay. So types of damage largely depends on the water solubility of the toxic gas. Highly water-soluble gases such as ammonia will react with the moist mucous membranes of the upper airway and cause swelling and irritation. Less water-soluble gases such as phosgene and nitrogen dioxide may get deeper into the lower airway, causing pulmonary edema up to 24 hours later. So again, what kind of work do you do, right? That's what you want to find out. Have you been exposed to any types of gases? Have you been wearing proper PPE during these times at work, right? All things you want to ask your patient as part of your assessment. Cystic fibrosis is a genetic disorder that affects the lungs and digestive system, right? This is caused by a defective gene that makes it difficult for chloride to be moved through the cells. This causes an unusually high sodium loss and an abnormally thick mucus secretion. Secretions cause breathing difficulties and infections, okay? So any kind of secretion you may have in the lung. This will lead to a lung disease. Patients that have cystic fibrosis, right? One of the things they do get is percussion therapy. So there's others, they have vibrating vest they can put on for it to help break up the mucus so they can cough it up and breathe better. Or they can do it the manual way by using either cups, specific special cups for percussion therapy, or you can cup your hands and hit the patient's back. And it's rapid, that type of sound, but on their back. It's rapid movement to break up. Now, you've got a patient with cystic fibrosis, they ask you to percuss their back. You can do that. Just cup your hands and beat the back of the patient so that way they can actually breathe better. It helps break up secretions. So symptoms range from sinus congestion to wheezing and asthma-like complaints. So look for respiratory insufficiency, signs of respiratory infection, and also intestinal blockage. Often causes death in childhood because of the chronic pneumonia that ends up killing these patients because they're so susceptible for infection to the lungs because of all that mucus buildup. Remember, because it's also because of the sodium levels are different. Right, so age-related conditions are like bronchiolitis, or an inflammation of the bronchioles due to a viral infection. Right, also caused by the metapneumovirus and respiratory syncytial virus, or RSV. A lot of hospitals are testing now with what they call a fourplex test, and it's done through a nasal swab, and they'll check for RSV, flu A, flu B, and COVID as one unit test instead of doing individuals, because right now it's hard to tell the difference of a lot of these. So they wanted to do one check and check them all. These primarily affect infants and children younger than the age of 2. So signs and symptoms are very similar to asthma for RSV, but asthma is also very rare in children younger than a year old. That's why we always test for RSV for kids. Infants with first-time wheezing episodes in the late fall or winter likely have bronchiolitis. So these are characteristics that our findings are mild to moderate retractions, tachypnea, diffuse wheezing, diffuse crackles, and mild hypoxia. Whereas respiratory syncytial virus, RSV, which is a common cause of illness in young children, which then causes an infection in the lungs and then the breathing passages as well. With this, it can cause other serious respiratory illnesses such as bronchiolitis and pneumonia. It also causes serious heart and lung problems in premature infants and children with depressed immune systems. RSV is highly contagious. So make sure you're wearing your masks and everything else to protect yourself. Croup, which is inflammation and swelling of the pharynx, larynx, and trachea, which is secondary to an acute viral infection of the respiratory tract. Very typical in children ages 6 months to 3 years. However, I've seen it in 10-year-olds before too. Easily passed between child to child, which usually starts with a cold or a cough or a low-grade fever that develops over the course of 2 days. The hallmark signs are stridor, which makes it an upper airway issue, and they have a seal bark type cough. So the peak seasonal outbreaks are in late fall and winter. Rarely seen in adults, but the most I ever seen, the highest age I've ever seen it, I believe, was like a 12-year-old. I've never seen it in an adult before. Which often responds well to humidified oxygen, which most of our services don't carry. Now, croup can, we're in that season now. We're going to start seeing patients with croup. A lot of times what they'll do is they'll put them into a warm shower where there's a lot of humidity. And a lot of times it will decrease the swelling, and they'll say, oh, my kid is perfectly fine. Okay, it might be. Or they'll bring them outside into the cold air, and then you notice that the seal barking cough is gone. If it's persistent and it stays with the fever and everything else, it doesn't hurt to call for a paramedic to be able to administer what they call racemic epi or nebulized epinephrine. Right? Nebulized epinephrine will help with that constriction of the vessels to reduce the inflammation to allow for better air passage. Okay, so you may have that opportunity to call for an ALS provider or paramedic to assist. But again, if they're perfectly fine, there's no airway compromise, and they want to go to the hospital, you can take that in at the A level. There's nothing wrong with that. Epiglottitis. This is a very, very dangerous inflammation. On top of that, these patients are very, very sick. This is an inflammation of the epiglottis, all right? And if the inflammation gets worse and worse, it can cause complete airway compromise and obstruction, usually caused by a bacterial infection that produces severe swelling of the flap over the larynx. This is predominant in children, but may occur at any age. So development of childhood vaccines against different diseases have dramatically decreased the incidence of this disease happening, but may completely obstruct the airway, right? So think about your epiglottis, right? The flap that goes back and forth from larynx to block the airway when you're eating, drinking, opens back up when you breathe. Imagine that swelling up to the point where it can't go anywhere and completely obstructs your airway. Signs and symptoms, usually a sudden onset. Patients look very sick, usually a sore throat, high fever, and stridor. May also appear in adults or geriatric patients, especially those with such as diabetes, caused by different bacterial viral organisms, can potentially be life-threatening, and deterioration can happen very quickly. There is nothing a paramedic is going to do in the back of an ambulance for a patient with epiglottitis. They need antibiotics, right? These kids need antibiotics at the hospital. Nothing we can do in the back of an ambulance. Now, I'm a big stickler on doing full assessments. If a patient has epiglottitis, another thing you're going to pick up on is excessive drooling, okay? If they have this and you suspect epiglottitis, please do not piss off the kid. If they start crying or any irritation, that will cause the inflammation to get worse, and therefore will potentially cause complete airway obstruction. All right? If you can get a pulse ox, great. On a kid, I'm not going to do blood pressures with epiglottitis because the pain on the blood pressure cuff can irritate the kid to start crying. Again, monitor. You can do blow-by oxygen with these patients if you want. Have mom hold the kid, or sit with the kid, not hold the kid, but sit with the kid in the back of the ambulance as they're more comfortable with the parents, and they can do blow-by oxygen administration if it's low. But do not irritate that throat, right? All right, pneumonia. So pneumonia is caused by an infection or a lung, like a lung disease. Hold on one second. Sorry, having a coughing fit for a minute. I'm still fighting some kind of respiratory thing as well. All right. So pneumonia caused by an infection of lung parasyncpa, which is the 8th leading cause of death in the United States. On top of that, it's also one of the most picked up infections in a hospital as well. So this is a group of specific infections, not a single disease. And the people that are at most risk are young children, older adults, because they don't have the ability to fight off those infections yet. Or they're older, they've lost that ability to fight off that infection, so they're more at risk. This presents as a localized infection in the lungs that may cause atelectasis, so the alveolar collapse. If not treated properly, it can become systemic, leading to sepsis and septic shock. Pneumonia is one of the most common indicators of sepsis. Signs and symptoms would include acute onset of fever and chills, productive cough with sputum, pleuritic chest pain, excessive mucus causing pulmonary consolidation. With that being said, patients with pneumonia with low SpO2 might benefit from CPAP, right, to help them bring that oxygen levels back up. Pneumonia can be very dangerous in the back of an ambulance, right, or in general. So having that quick treatment, that crutch to help them breathe, if they need it. Keep in mind, if they need it. If they need pulmonary support, then that's what our CPAP is for, is pulmonary support. All right, let's see, pertussis. So pertussis is an airborne bacterial infection. Mostly affects children in younger ages of younger than 6 years of age. It's highly contagious and passes through droplet infection. What you'll have is a whoop sound, like whooping cough, right? Coughing attacks. They'll be feverish. They'll have a cold-like symptoms, but coughing spells can last for more than a minute. And the child may turn red or purple. Right. Other age-related conditions, airway obstructions. Obviously, looking at the elderly, geriatric, and then pediatric as well. Always consider the possibility of foreign body airway obstruction when a young child becomes short of breath. Did they get into something? Remember, children are very, very adventurous. Tonsil inflammation may also partially occlude the airway as well. Dysfunction of the tracheostomy may also create upper airway obstruction if they have a trach in place. Obstruction may also be in the lower airway below the vocal cords, where they could have tracheal trauma, obstructive lung disease like pneumonia, mucus accumulation, asthmatics, or smooth muscle spasms. So edema may also be present when a patient has been exposed to a toxic chemical or superheated air. Because kids never get into that kind of stuff, right? Never. We're going to cover more on the toxins when we cover toxicology later on, right? Cover more of that in detail. Heart failure. Obviously, heart muscles are injured by a heart attack or an illness that may not be able to. Stand by a minute. For some reason, Adobe just opened up on my computer. Let's close that. There we go. That's better. May not be able to maintain cardiac output that meets the need for the body. Therefore, the patient has heart failure. Okay, so we may have patients that have right-sided heart failure, where we cannot pump enough blood into the heart or into the lungs and through to the left ventricle from the right ventricle, right side. Therefore, backing up in the extremities, causing jugular vein distension and also causing edema to the extremities. But if we have left-sided failure and our heart can't pump as fast as the right ventricle is pumping into the lungs, that fluid has to go somewhere, and that path of least resistance goes to the lungs. Therefore, now we have pulmonary edema. So other risk factors with pulmonary edema would be hypertension, so history of coronary artery disease or atrial fibrillation as well. So in most cases, patients have a long-standing history of chronic heart failure that can be controlled with medication, right? So what medications may you see for patients who have heart failure? Give me some meds you may come in contact with.
Lasix.
Yeah, Lasix, torsemide, right? Brosemide. What else?
Dig.
Old school medication, not given as much, but still out there. Okay, digoxin. Things to pick up on. Dig toxicity is very dangerous, right? So if a patient had digoxin or dig toxicity, what would you most likely see for what would the patient most likely have for symptoms? What do you think? As I plug my computer in, what do you guys think? Dig toxicity. So they could have potential for chest pain. What else?
Probably some sort of arrhythmia.
Okay, yeah, they'll have an arrhythmia. And on a 12 lead, and again, we haven't gone over that kind of stuff yet, but you'll have where the J point is on a 12 lead, it'll be more like an ice cream scoop. So you'll probably see that on a 12 lead. And the other big one is yellow vision. So the patient will actually have yellow vision. So that's another thing of ditch toxicity to pick up on. So the patient's on digoxin, ask them, do you see yellow? Do you see yellow? Do you have yellow vision? They say yes, then it's probably a ditch toxicity issue. All right. Hydrochlorothiazide is another medication, HCTZ or hydrochlorothiazide, also removes fluids from the body. So understanding pharmacology will help you with patients that are altered. They can't tell you their medical history, looking at what they have for meds. So other signs and symptoms, obviously, would be difficulty breathing with exertion, sudden attack of the respiratory distress, coughing, feeling suffocated or feeling like they're drowning internally, cold sweats, and tachycardia. So patients that have congestive heart failure or acute pulmonary edema, these patients need to be treated with CPAP and nitrates, as long as the blood pressure is high enough. So to kind of go over the difference between wet versus dry lungs, right? Wet lungs are associated with pulmonary edema. They sound like there's fluid, there's rales, right? There's a lot of water buildup inside the lungs, fluid buildup. Potentially it will be pink and frothy, because remember, they're going to start this blood also mixing in with this fluid, transferring into your lungs. Dry lungs are associated with COPD. So if you look at table 17.6 in your books, this will compare the difference between COPD and heart failure. Treat the patient, not the breath sounds. What do you see for a patient? All right. This has been the battle for many years on how we treat this. You know what? One thing we do for both is CPAP. The big question is do we give a neb inline or do we give them nitrates? So treat your patient. Look at your vital signs. All important aspects, medical history as well. If they have had COPD exacerbation before and you hear dry lungs, it probably is COPD exacerbation. We're going to treat that with bronchodilators. If we give someone with acute pulmonary edema and congestive heart failure a bronchodilator, we're going to potentially flood our patient. They'll flash and they'll end up dying. There's a difference between the two. So no COPD and no pulmonary edema, CHF, right? It's always been the hot topic for many years on how we treat this. The one thing I can say is they're both treated with CPAP. And that's a skill we can do at the basic level up. All right, so as far as patient assessment goes, right? Use additional PPE if COVID-19 exposure is a possibility. Again, it's still out there, right? Protective N95, goggles, gloves, protective coverings for clothing. Ensure that the scene is safe. Determine the number of patients and the need for specialized resources, and consider the possibility of an airborne hazardous material release. If I have 5 patients down on the ground, I'm going to suspect hazmat. If I have 1, could it be a carbon monoxide issue? Possibly, right? I know New Hampshire and Massachusetts have now mandated that they have to have a carbon monoxide meter on every first in bag. Okay, so all of our bags have them on it because it's required for a 911 system. So if you enter the home and it goes off, you turn around, you walk right back out. Right, now we're going to do our primary survey. Recognition of life threats and the initiation of resuscitation take priority. If they're in cardiac arrest, we start CPR, compressions, airway breathing. there's a life threat, we need to fix it. Signs of life-threatening respiratory distress in adults would be altered mental status. This is critical patient. Altered mental status, severe cyanosis, absent or abnormal breath sounds, audible stridor. When you walk in, you hear the stridor without even using the stethoscope. 2 to 3 word dyspnea, coughing, tachycardia of more than 130 beats a minute, abnormal breathing, change in respiratory rate or rhythm, pallor, diaphoresis, the presence of retractions and or the use of accessory muscles and tripoding. Another one that should be on here is pursed lip breathing as well. If you have these when you walk through the door, the patient is considered critical, and you can do more of an assessment and stabilize the patient. All right? Any questions on primary survey? So we got more to go, but no? Okay, good. There we go. So we want to note the general impression of the patient. Are they sick or not sick? We have to make that determination right away. If you walk through the door and they look like crap, they're sick patients. Let's get them in the back of our office, the ambulance. Let's start initiating transport and treatment, right? If they don't look sick, then we have a few minutes to do more of an evaluation in the home, right? But certain things need to be done in the home, and that's stabilizing your patient. If the patient needs CPAP, the last thing you want to do is wait 10 minutes to get them out and start them on it. That may be too late. But keep in mind that CPAP does use a lot of oxygen out of your tank. So please make sure you do your truck check in the mornings and make sure your tanks are full. Because CPAP can drain a tank pretty quickly depending on which system you utilize and how much oxygen is being utilized to pressure your system. All right. Determine if the patient is breathing. If they are unconscious and they're not breathing, CPAP is contraindicated. Determine if the airway is open and clear. Provide the appropriate oxygen therapy or positive pressure ventilations. If ventilating, determine if ventilations are effective. Listen to lung sounds. Look for chest rise. Are we seeing our end tidal change? Are we seeing our oxygen saturations increase? Are they decreasing? Right? Assess the pulse rate, rhythm, and character. Put them on a cardiac monitor. Tachycardia or bradycardia indicates patient may not be getting enough oxygen. This is why it's so important to put patients on cardiac monitors. Start them off with a 4-lead and get your 12-lead. You as AEMTs can monitor that. You can see tachycardia and bradycardia. You can see your end tidal, you can see your oxygen, you can see your respiratory rate based on your end tidal readings. Accurate, real-time information on how you're currently treating your patient. We're going to assess for shock and bleeding as well, part of our ABCs. We're going to check cap refill in infants and children to make sure they're perfusing appropriately. And we're going to check perfusion by evaluating skin color, temperature, and condition. We're then going to identify any life threats, problems with the airway, breathing, and circulation. If we have problems with that, let's take care of it. We're going to look for any poor general impression. If they have an altered mental status, potential hypoperfusion or shock, looking at our vital signs. Also looking at history. Chest pain associated with low blood pressure. Severe pain anywhere. Excessive bleeding. So if the patient is unstable and there is a possible life threat, address the life threat and proceed with rapid transport. If the patient is stable and there is no life threat, you may decide to perform a thorough secondary assessment on scene after obtaining a patient history. That also includes vital signs. When we're checking lung sounds, we want to make sure we do a great job assessing. Okay? 6 points in the back, 4 points in the front. Okay? So lung or breath sounds is one of the most important vital signs for your patient in respiratory distress. The last thing you want to do is give the wrong medication if you didn't hear a lung sound or didn't check it. So we're going to listen over a bare chest. Pull their shirt up and listen. We're going to use the diaphragm of the stethoscope, must be in firm contact with the skin, And we're going to bring your patient to a seated or sitting position. As we determine, listening to lung sounds, if they're normal or abnormal, we'll be able to determine how we're going to treat our patient. So vesicular breath sounds represent air moving in and out of the alveoli. Bronchial breath sounds represent air moving through the bronchi. Adventitious breath sounds or decrease, absent, or abnormal. So what are they? What do they sound like? Rate, rhythm, and quality. So with your stethoscope, check breath sounds on the right and left sides of the chest and compare each side. This is why we don't go down just one side or the other. We go in a pattern, right to left, or left to right, left to right. Listen for a full respiratory cycle. The one thing that pisses me off the most in a doctor's office is when they go in there and say, okay, we're going to listen to your lung sounds, and they check it and say, go ahead and take a deep breath. You take a deep breath in, and then they move to a different part of the lung. Okay? They don't get a true set of lung sounds. It agitates me. Inspiratory, expiratory. Then move your stethoscope. In, out. Move your stethoscope. All right? Don't skip. Get good lung sounds. Use your stethoscope and the check breath sounds on the right and left. Compare. Listen for a full respiratory cycle again. All right, and then look for the abnormal breath sounds you may hear. Crackles are fine crackling sounds of air trying to pass through the fluid in the alveoli. When would you have crackles? In what situation? Give me one situation where crackles would be.
CHF.
EHF, yeah. So tundra pneumonia could have crackles, but also rhonchi as well. So I gave you guys that one away, but there's other ones too. Rhonchi are lower pitch sounds caused by secretions or mucus in the larger airway. When would you have rhonchi other than pneumonia? Yeah, pulmonary edema. Thanks, Kenny. Yep, exactly. CHF. When would you have rhonchi other than pneumonia?
Asthma?
Asthma and,
Bronchitis.
yep, so COPD, right? Acute or chronic bronchitis, bronchi. What about stridor? Stridor is a high-pitched sound heard on inspiration, and air tries to pass through an obstruction in the upper airway. When would you hear stridor?
Anaphylaxis.
Foreign
Anaphylaxis.
object.
Yep, foreign object. Matt O'Connor said choking.
Croup.
Yep, croup. Exactly. Good job, guys. This is awesome. Wheezing is a high-pitched whistling sound typically heard on expiration that indicates constriction and or inflammation of the bronchus. And when you hear wheezing,
Asthma.
asthma, COPD. What else would cause wheezing? Anaphylaxis. What else? Do one more. How about airway burns? Airway burns can cause wheezing as well. All right, so now we have pleural friction rub, which is a squeaking or a grating sound that occurs when the pleural linings rub together. And then snoring sounds, which would be a partial upper airway obstruction. Awesome. We're all on the right page here. This is good. So let me get our sample history, okay? So patients in respiratory distress require a sample history. Signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up to what happened. This can be determined from the family or bystanders if they are present. Limit the questions to pertinent ones, okay? Remember, they're already having difficulty breathing, so we don't want them talking too much, right? So limit your questions to ones that pertain to what you need to find out to treat your patient. Be sure to ask the following questions about the patient in respiratory distress. What is the patient's general state of health? Has the patient had any childhood or adult diseases? Have there been any recent surgeries or hospitalizations? Have there been any traumatic injuries? Is there any dyspnea or chest pain? If they have dyspnea or COPD exacerbation, status asthmaticus, add into the questioning, have you ever been intubated before? If they say yes, then call for a paramedic because this patient could turn south quickly. All right. Ask the appropriate, pertinent questions. All right. If time allows, also ask about immunization history. It's good to know about the immunization records. If you have time, ask about previous episodes, medication allergies, and current medications. Because we're going to start treating our patients, we have to know what they're allergic to, right? That also includes not just medications, but other environmental factors and food as well. One of the contraindications for a patient with a duoneb, and not talking about albuterol, I'm talking about the other side, ipratropium bromide, is sometimes patients can have a reaction to it if they have an allergy to soy products. So again, another question to ask them. A patient that you're giving aspirin to, okay? If they're asthmatics, then I would contact medical control prior to, because aspirin can trigger an asthma attack, especially patients that are fragile asthmatics. We also don't want to give aspirin to anybody under the age of 18 because of Rye syndrome as well. Okay, so there's a lot of different things that maybe you have heard before or never heard about before at all. But again, medications and history tie in together, especially with things that you're going to be administering in the back of an ambulance. If medical can pay close attention to the medications they're currently taking, if medical control permits, you may administer a bronchodilator via a nebulizer. In New Hampshire, we can give duonebs and albuterol, right? We're going to reassess frequently and be prepared to assist ventilation in severe cases. Give a medication, reassess. Give a medication again, reassess again. You want to see if the patient is getting any better with your treatments and then document. We're going to use the OPQ-STI mnemonic to determine the specifics of the pain and obtain specific information about that breathing problem. When did it begin? Onset. What makes the breathing difficulty worse or better? Palpitation, provocation. How does the breathing feel? That's your quality. Does the discomfort move, radiation, or region? How much of a problem is the patient having? Severity. On a scale of 0 to 10, I hate people that use 1 to 10. I hate that with a passion because 1 is still a problem. Either it's nothing going on at all or it's the worst you've ever felt, scale of 0 to 10. 10 being the worst pain or difficulty the patient's ever had, how bad is it? If the problem is continuous or intermittent, if it is intermittent, how frequently does it occur and how long does it last? That's your timing, right? What has been done to alleviate the problem prior to EMS arrival? Were there any interventions that were taken or meds? So did they take an EpiPen? Did they take Benadryl PO? You know, those are all good information. Do they take an MDI inhaler? Do they have their own nebulizers because they have COPD, right? Do they pop a nitro because they have CHF or chest pain? So you want to get all this information and take note of all that. That's going to determine on how you're going to treat your patient and what other medications you're going to give them. Does the patient have a cough? And if it is a cough, is it productive or non-productive? If it's productive, what color is the sputum? Any increased sputum production at all? Is there any hemoptysis, wheezing, fever, chills? Has there been any exposure to smoke, or does the patient have a history of smoking? All very important questions when you're dealing with a respiratory patient, right? It is now 8:08. We're about 3/4 of the way done. Why don't we take 10 minutes, come back, and then we'll finish it up, right? All right, see you guys in, so 8:08, so let's say 8:18.
This conference will now be recorded.
All right, so as far as chronic respiratory conditions go, we look at patients with chronic conditions that may have long periods in which they are able to live relatively normal lives, but then sometimes experience acute worsening of their conditions, and that's where we get that whole exacerbation deal. So chronic lower airway obstruction makes it very difficult for patients to breathe deeply enough to clear the lung. So if there's a new infection of the lung in a patient with COPD, the arterial oxygen level may fall rapidly. And these patients may require CPAP, BiPAP, or if they're that bad and they become altered, RSI and intubated. So with these patients here, usually have a long history of dyspnea with a sudden increase in shortness of breath. They rarely have a history of chest pain with this. You'll see the pulse become rapid and occasionally irregular. So really pay close attention to the respirations and see if anything's actually going to change. Especially when we start seeing more tachypnic respirations, then we have to start making these changes, whether we utilize CPAP to fix stuff or BVM to control, or they need to be ALS paramedic to be intubated. So patients with asthma maybe also have different triggers as well. So determine what may have triggered that asthma attack. Dander, dust, were they on the floor? I had a patient he was like 17 years old, chronic issues with asthma. And a lot of his triggers were just dust and things built into a carpet. So if he was laying down on a carpet, rolling around, playing or whatever, doing whatever he was doing, right, it would trigger an asthma attack on him to the point where we had to actually go as far as giving him epinephrine to control it. This is a chronic thing with him. We would go there probably once a month. This kid would get epi once a month from us on the ambulance because of it. So you just got to pay close attention, and you want to find out what those triggers are with the asthmatics for these chronic conditions. What made it worse today? What did you get yourself into? Did something change? And you want to find out what that potentially could have been. All right. So as far as the secondary assessment, this is where we start going more in depth in our assessment of the body systems, right? Remember how before I mentioned you have to take that next step, that next level of assessment, looking at the pathophysiology, what's going on inside the body, not just, oh, well, the protocol book says they have this with wheezing, we give this. Why are we giving something? Why are we doing this, right? So this is our more in-depth assessment. We're going to address specific chief complaints. We're going to include a physical examination and taking vital signs as well, okay? Detailed vitals. We're going to perform after identifying and treating life threats, okay? We don't go into a detailed assessment if the patient does not have an airway. A change in mental status is one of the early warning signs of respiratory inadequacy and indicates a lack of perfusion to the brain. If they have altered mental status, all right, they cannot, contraindicated, cannot receive CPAP. You have to go to a BVM. Right? So look for the overall symmetry of the chest, adequate rise and fall of the chest, and evidence of retractions or accessory muscle use. Right? Check respiratory status, rate, rhythm, quality. Looking for the slowing respiratory rate with an unimproved condition suggests physical exhaustion and impending respiratory failure. An AEMT cannot handle respiratory failure. These patients really need to be intubated, okay, if they're going into failure, or they need a medication like a smooth muscle relaxant or the smooth muscles like magnesium sulfate, and also getting steroids on board as well. So look for signs of increased work of breathing. If we see that, we need to start treating it. If they have an increased work of breathing, that's perfectly fine. We can start treating that with CPAP as long as they're alert and oriented. Once they change status, they got to go to a BVM. So many smokers and people with chronic respiratory diseases cough up sputum every day. So to determine if the color or the amount of sputum has changed, note whether the mucus is like a pus-like mucus. Secondary assessment of the cardiovascular system should include checking and comparing distal pulses, reassessing skin condition, be alert for bradycardia and tachycardia rhythms. Right? What's not on here because it's not national scope, it is New Hampshire and Maine, is 12-lead EKG. Get a 12-lead. Check for any signs of trauma or retractions to the chest. Could the shortness of breath be from a GSW or a stabbing? Numbness, tingling, carpal pedal spasms may also be associated with hypocapnia. Okay? So, low carbon dioxide, resulting from periods of rapid deep respirations. Blood pressure should be auscultated when possible. You want to feel the skin temp. Look for color changes in the extremities and in the core of the body. Do a neurologic assessment. Okay, so stroke assessments all the time. Just because they didn't have any signs and symptoms of a stroke when you first started does not mean it hasn't changed. Right? Do a neurologic system check frequently. Right? CSMs, everything present, equal, bilateral. Monitoring devices. We have peak flow meters, which we do not use in the back of the ambulance. Okay. However, end tidal, pulse oximeter, right? Those are things we need to utilize. If they have a peak flow meter at home, ask them what their range has been. Okay. Have they been meeting their target numbers? Right. Patients that have target flow meters are usually patients that have had pneumonia before. They may have had previous rib fractures, and they're trying to make sure they can expand that lung so there isn't an increased amount of dead space causing pneumonia or residual air. Then we're going to do our reassessment. Repeat the primary survey. Maintain an open airway. Monitor the patient's breathing. Repeat 12 leads if need be. Reassess circulation. Determine if there have been any changes in the patient's condition. Confirm the adequacy of interventions and patient status. So did you give medicine, medications administered, and reassess them every 5 minutes to make sure there's a change? Bronchodilators like albuterol or duonebs work fairly quickly. It's not something that you give like a steroid that medics get to take 45 minutes to work, right? We're giving life-saving medications quick that have fast onset of mechanism of action. Looking for skin color and temperature. Be prepared to assist ventilation to the BVM, right? If the patient starts going unresponsive or starts having significant difficulty breathing with no changes with CPAP, it needs to come off. We need to ventilate our patient. Remember, 5 for unstable, 15 for stable patients, right? We're going to perform standard interventions. Oxygen, we want to keep that saturation above 94, but less than 100, okay? Intravenous access, 1 line, if not 2. Critical patients should be receiving 2 IV lines, all right? Keep that in the back of your head. I'm not saying waste your time working on a second line. Get 1 line in, start more interventions, and then if you have time to throw your second line in, then do it, all right? Decrease work of breathing. Please do not lay the patient supine, okay? We do not want to distribute any kind of fluid or cause any more increased work of breathing. Any kind of restricted clothing. So bras on a female, take them off, cut them. All right. Allow for their chest to allow for full expansion. And please, please, please do not make these patients walk. Right? Utilize stair chairs. I don't care if it's 20 feet. If you can bring a stretcher to them, great. If not, do not walk these patients, okay? It's just going to make the exacerbation get worse, and it's going to cause more damage than good. Provide supplemental oxygen. use your pulse oximeter it's a useful guide, but again, it's a guide, it's a tool, right? Pulse oximetry is useful in conjunction with end tidal. It's safe to administer oxygen in concentrations less than 50% to almost anybody. Okay. So oxygen concentrations higher than 50% should be reserved for patients with hypoxia that does not respond to lower concentrations. The use of 100% oxygen should be limited to the shortest period of time necessary. Never hesitate to administer oxygen aggressively, though, to those who definitely need it. And you want to maintain between 94 and 99. We should really be avoiding 100%. And consider insertion of advanced airway adjuncts if unresponsive patients and call paramedic for backup. So let's go back a little bit. All right, let's have a discussion on this one here. How do we know what percentage of oxygen is being administered? It's safe to administer concentrations less than 50%. Okay, so what devices do we have, or devices, do we have that delivers percentage of oxygen at a lower number? So Justin, you said your delivery apparatus, right? So if you have a nasal cannula plugged into the wall of the ambulance, how would you know what percentage of oxygen is being given?
By how many liters you're using?
So not so much as far as liters, but how much that device can actually deliver. So one of the things I need you guys to memorize, and this is very, very important, is not just liters per minute of oxygen, but percentage based on what you're administering. So I'm going to give you guys some numbers, okay? That's very important. Nasal cannula, 1 to 6 liters per minute, delivers between 22 and 44% oxygen. Non-rebreathers, between 10 to 15 liters per minute, delivers 90% oxygen. A BVM, 15 liters per minute, delivers 100% oxygen. CPAP delivers 100% oxygen, right? Unless it's on a ventilator, then you can measure or set your FiO2, fraction of oxygen, percentaging, right? And at the AEMT level, you guys are not using vents, right? Now, do we need to cover a simple mask and all that? 60% for a simple mask? No. The chances of us ever using a simple mask in the ambulance are very, very slim, if any at all. And I haven't seen a service carry a simple mask in years. But we carry nasal cannula, non-rebreather, and we also carry the BVM and CPAP, right? So what they're asking you to do is start low. Nasal cannula delivers between 22 and 44%. Once we go to a non-rebreather, it's 90% oxygen. Now, short durations. That's why when you get to a hospital, patients that are on non-rebreathers in the ambulance, you ever notice the hospital staff always takes it off, puts them on nasal cannula? Because you gave them that short, aggressive treatment. Now, if the patient's being CPAP, that means that you've tried other alternatives and this patient can no longer breathe very well at 100%. That's okay. When you get to an emergency department, they're going to take off your CPAP device. They're going to put them on something called BiPAP, which is bi-level pressure, where they can set the inspiratory pressure and the expiratory pressure, and they can also adjust the FiO2 percentage, right? So again, what we do is short term, all right? What we're doing is short term aggressive treatment to get that patient out of that hole that they're currently in. Does that make sense to everybody? Right? Be aggressive with respiratory patients because respiratory failure is right around the corner, right? Be aggressive. I didn't say be a cowboy. I said be aggressive with your treatments, right? Do what's best for patient care, right? What's best for patient care. So now we're going to talk about bronchodilators. Okay, so we're going to administer a bronchodilator. We carry two different ones to administer at the advanced EMT level, and that's albuterol and duoneb, which is albuterol and ipratropium bromide. So patients who do not have bronchospasms usually benefit only slightly from aerosol bronchodilators. Bronchodilators are of little value in treating conditions such as pneumonia, pulmonary edema, or heart disease. Now, bronchodilators can help with pneumonia if there is wheezing or bronchoconstriction. Other than that, what they really need is either pressure support, which is CPAP, with low oxygen percentage, or they can use medical air for those as well. Or they also need antibiotics. Reserve our bronchodilators for patients that actually truly have bronchoconstriction. And how do we know about bronchoconstriction with end tidal? What waveform is that called again? Exactly, shark fin. My goodness. All right, so respiratory medications, most common medications are inhaled beta agonists, okay? Typical trade names are Preventil, Ventolin, Alupent, Metoprel. Those are all different ones that can be utilized. They relax the smooth muscles within the bronchioles and in the lungs. The bronchodilators relax the smooth muscle around the larger bronchi, which is a fast-acting bronchodilator that provides rapid relief. Right? Bronchodilators do not reduce swelling. They do not kill bacteria. They do not push fluid out of the lungs, and they do not open closed alveoli. Okay? It does what it says it does. It bronchodilates the bronchioles. Well, dilates the bronchioles. Secondary bronchoconstriction could be reversed with a bronchodilator. Right? So if you look at table 1710, this lists the medications used for acute and chronic respiratory symptoms. Now, there are other medications that they use, powders and things like that, that the patient may receive from their primary care, but nothing we're going to give in the back of the ambulance. What you guys have access to are your duonebs and your albuterols.
Wendy? Whitney.
So what used to be common a while ago, somebody's unmuted. Another one that was out for a while but was very expensive was called levobuterol or Zopanex.
Huh?
That didn't have a lot of the effects
To Whitney? No.
from before.
Hey, what? What are you doing to your stuff? Oh, oh.
Rosa, I think you're unmuted. There we go. All right. So again, take a look at that list on 1710 as well. So with that being said, aerosol therapy. So aerosol nebulizers deliver liquid medication into a fine mist. To generate optimal particle size, most nebulizers need to have a gas or oxygen flow at 6 liters per minute. Not many ambulances carry medical air, okay, unless they're on critical care trucks or transfer trucks that have, paramedics. Like where I work, we have 2 trucks that have medical air ability, right? You can use medical air for these because they don't need oxygen to create the aerosolization, right? But if that's all you have, that works perfectly fine. Nothing wrong with that at all. So we're going to put at least 6 liters per minute. If you go higher than 6 on these, a lot of times it blows the line right off of it. So again, 6 liters and run it through, right? This is what it would look like. This is what I call the peace pipe. So this is a nebulizer that can be attached to a mouthpiece and a face mask or a trach collar or held in front of a patient's face. What we want to do is make sure that medication, if you can see my mouse on the screen, is being aerosolized in here. So you pour the medication inside this chamber, screw the top back on, apply oxygen or air through the line, aerosolizes up into here, You have the patient take a deep breath. Okay. Now, they make, and then if the patient's not breathing appropriately or they're in between breaths, the medication starts dispersing through the tube and out into the air, which is why patients that have COVID that are receiving these, you want to have a good ventilation system and N95 masks on because they're now breathing aerosolized particles out into the air through the nebulizer, right? These patients also may have repeated treatments as well for these, but this is how we use a neb. They do make face masks, so this chamber connects into the bottom of what would look like a non-rebreather mask, and then the T-piece is gone. Or you have a CPAP device that this piece from here down connects into the bottom of a CPAP where you can run it inline, but that requires 2 different oxygen ports. Okay, so you're just going to kind of keep that in mind. Meter dose inhalers. This is what you would find any patient that has asthma or COPD would have these. So the proper way of utilizing these here would be to make sure that it's in date, right patient, right time, right medication administration, the whole deal, right? Shake it first before administering. And then you have, this is called a spacer in between. Spacers are great because it helps deliver a more appropriate dose of medication versus using it without it. All right. You want to have the patient expel all of their air and then take a deep breath as the medication is inside the spacer, pulling deep into the lungs. By doing so, you want to have them hold their breath for about 10 seconds or as long as they can, up to 10 seconds. That way there, it'll allow the medication to get deeper into the bronchioles to help bronchodilation. All right, so we already covered all this here. Common things to avoid also. Ensure the mist enters the lungs. Hold breath deeply. So spacers work a lot better. I never gave out an albuterol MDI in the hospital without giving a spacer with it because it's more accurate medication administration. So contraindications would be the patient unable to help coordinate inhalation, so they can't do it on their own, and they can't coordinate it, they can't take it. If it's not prescribed to the patient, we don't give it. Do not obtain permission from medical control and/or it is not permissible by local protocol. The patient has already met the maximum prescribed dose before your arrival. Now, just because they met the prescribed dose of an MDI does not mean that you withhold albuterol or Duonems. You follow your protocol from there. If the medication is expired, they don't get any more, and other contraindications specific to the medication as well. About 5 minutes after the patient uses the inhaler, repeat the vital signs and the primary survey to see if there's any changes. Listen to lung sounds. Believe it or not, giving these medications literally can make wheezing go away. So you want to make sure you do your reassessment. Dry powdered inhalers, which we do not carry, reasonably convenient and easy to use, rarely used in emergency care. A lot of times you'll see these patients have them for like long-term therapy. They take it once a day, things like that. Consider fluid balance. Common practice to give fluid boluses to younger patients with these conditions. You know, in any older adult or other patient with cardiac dysfunction, administering too much fluid could actually cause pulmonary edema. So we want to make sure we're reassessing our lung sounds every 250 mLs, make sure fluid isn't shifting into the wrong spot. Always assess breath sounds before you give a fluid bolus, and you always want to have an IV line in place, right? Even if you're giving these nebs, because a patient can have a change. Bronchodilators are beta agonists, which means they have beta 1 and beta 2 effects on the beta receptors. Beta 1 being the heart and rates, and beta 2 being the bronchodilation of the lung. So you're going to see tachycardia with these patients you're giving these medications to. So we're going to support or assist ventilation if the patient becomes fatigued, and you can administer an inline neb through a BVM, right? That is allowed to be done. Some patients may simply require a bag valve mask for a short period of time. Just keep in mind that as you're ventilating, gastric distension and vomiting can occur from over-aggressive ventilation. So anytime the patient takes a breath in, give just enough of a squeeze to help maintain that, okay? We're not just gonna try to override them. We're gonna ventilate with them to control that and bring their oxygen levels back up. Continuous positive airway pressure is used to treat obstructive sleep apnea and treat respiratory failure. If a patient's in failure and they're altered, they're not going to be on BiPAP or CPAP. They're going to be intubated. Many people with obstructive sleep apnea wear CPAP at night to maintain airways during their sleep. Remember, these are not oxygenated, right? Room air, 21%, right? But the CPAP is used for therapy for respiratory failure is almost always delivered through a mask secured to the face by some type of strap, as you see here, okay? Now, there's a difference between sleeping and truly unresponsive, right? So we want to make sure that our patient is not unresponsive when we're putting these on. Continuous positive area pressure administering CPAP increases pressure in the chest. So you have to be vigilant about monitoring the gas supply because it does use a lot. And CPAP can turn a simple pneumothorax into a tension pneumothorax in only a few breaths. So contraindications to this. It can cause barotrauma, which then can reduce blood pressure, okay? So hypotensive patients should not be getting CPAP. They should be bagged, BVM. Pneumothorax is another one, unable to maintain their own airway. If they're nauseous with vomiting, we're not putting this on them, okay? Because if they vomit in the CPAP, it's going to push it in their lungs. They're going to aspirate, and then they're going to become very infected. Pneumonia sets in, and everything else. The patient can die from that, become septic, right? If a patient doesn't want to use the mask, then don't let them use it. But the best option with this is to let the patient administer to themselves at first so they can see that it actually works and allow them to build up that trust with that device. The success of CPAP is inversely related to the patient's respiratory rate soon after its application. If the rate increases, the therapy is likely to fail. If the rate decreases, the therapy is likely to succeed. It happens fairly quickly. It's not one of those things where you're going to see a change in 10 minutes. You're going to see it within the first minute or two. The patient will start feeling relief and being better. If it's not changing, then you got to find something else, right? Try a different method. BVM, medicine, paramedics on board, things like that. So this is BiPAP or bi-level pressure, where one pressure can be delivered during inspiration and a different pressure be delivered during exhalation. This is not an advanced EMT skill. Way more comfortable for the patient. It can cause pressure variation in the chest, which allows for more normal blood flow, therefore not decreasing our blood pressures and causing more damage. It's more complex and expensive. However, they do have devices now, and I actually have one that is a CPAP BiPAP disposable mask, but still not allowed in New Hampshire at this point in time, and also not allowed at the advanced EMT level. All right, so to kind of finish up here, we're getting very close to the end. Let's cover more management of specific conditions. So upper and lower airway diseases. So the patient presents with signs and symptoms or signs of severe respiratory impairment. May include 1 to 2 or dyspnea, diminished or absent breath sounds, right, and altered mental status. The chief complaint is typically dyspnea, cough, or nocturnal dyspnea. If you want to make sure we obtain a thorough history, include personal and or family history of asthma or allergies. We're going to determine whether the patient has an acute exposure to a pulmonary irritant or previous similar episodes. If wheezing is present, it may become present. So we're going to use a peak flow meter to establish the baseline expiratory airflow if they have one. We do not carry these on the ambulance. We're going to use a pulse oximeter to document the degree of hypoxemia and response to therapy. And end title. Consider calling early for a paramedic backup if the patient is in severe distress because we have more medications at our disposal than the advanced EMTs do. Doesn't mean that you wait for us to get there. Start treating your patient. We're going to consider monitor airway, apply high flow oxygen, and assist ventilation if needed, or apply CPAP if needed. Humidified oxygen if you do have it. Establish IV access to provide circulatory support. Assist with an MDI. Continue monitoring. Obtain a 12 lead. Transport. Provide psychological support if needed. And then medical control can be your friend. They can help you through it. For acute pulmonary edema, this may be associated with cardiac disease or direct lung damage. So administer 100% oxygen. If necessary, carefully suction secretions from the airway. If the patient, place the patient in a position of comfort. We're going to provide continuous positive airway pressure, CPAP, which has been proven very beneficial in CHF patients. IV access, monitor flow rates carefully because we don't want to flood the patient with fluids. Paramedic backup for intubation if needed. If the patient's hypertensive and your protocol allows you to give nitrates, then give nitrates. Okay. The only drawback is that you may have to pull the CPAP off the patient, right, if they're going to receive nitro. We do not give nitrates to a patient without having an IV in place. Aspiration is an inhalation of anything other than a gas. It's associated with a high mortality rate, which is why it's so important to make sure that when we're ventilating patients, we want to avoid gastric distension. We want to aggressively monitor the patient's ability to protect his own airway and aggressively treat aspiration with suction and airway control if the previous steps fail. Monitor them. If they're nauseous, give them Zofran, okay? Give them an antiemetic. Prevent vomiting. Keep them sitting up. Give them antiemetics, right? If they're nauseous and you can't get an antiemetic on board right away, they can sniff an alcohol prep. It's within the scope of practice as an EMT. And the smell of the alcohol prep, in turn, is supposed to reduce nausea, right? If they're not vomiting and they can get an ODT Zofran, that's perfectly fine. You put it on top of the tongue, let it dissolve. COPD, we've covered that quite a bit. Patients that have an altered level of consciousness, right, have a potential for, get to that. Patients that have an altered level of consciousness often have significant decrease in pulse oximetry. That's where I was going with that. So patients often find breathing difficulty while lying down, and they feel better when they sit up. So we want to assist with prescribed inhalers if they do have one, but patients will often overuse an inhaler, so watch for the side effects, right? So sympathomimetic side effects would be what? What would you see for sympathomimetic side effects? Yep, tachycardia. So complete, so we're gonna lose my spot here. So we're gonna ensure we transport these patients as promptly as possible to the emergency department, allowing the patient to sit upright if that is the most comfortable for the patient. Patients who have auto PEEP, which complete exhalation must be allowed before the next breath is delivered. That's auto PEEP. This can eventually cause a pneumothorax or cardiac arrest, and where patients whom auto PEEP is a concern should be ventilated at a rate as little as 4 to 6 breaths per minute. So here's asthma with the asthmatic triangle over here. So we're going to assess the assessment of the patient is critical for asthmatics, right? I've seen kids turn quickly for the worse that aren't treated aggressively for asthmatics. This is often a recurring pathologic problem or condition, I should say. So if possible, ask family members to describe the patient's asthma. How bad has this gotten? Have they ever been intubated before? Have they ever received epinephrine before? There are three components to asthma, and they are bronchospasm, airway edema, and increased mucus production, right? For the longest time, CPAP was actually contraindicated for patients that were asthmatics. Right now they're saying that it does work, but really what they need is the dilators. So ask questions about how and when the symptoms began. Remember, when you're assessing a pediatric patient, look for any kind of retractions, nasal flaring. Be prepared to suction, administer O2. So airway edema, we treat with corticosteroids. Okay. At the A level, you do not administer it. Paramedics carry dexamethasone and solumedrol. Increased mucus production, treat with water. Again, something else that we're not going to be doing in the field. And then bronchospasm, treat with bronchodilators. That we can do, right? So if the patient has a medication, help administer the inhaler or nebulized medication as directed by local protocol. If you must assist ventilations, use slow, gentle breaths. Remember, we do not want to overventilate these patients, causing gastric distension and vomiting. Right? Emergency care of a child is the same for an adult. Right? Albuterol, Duoneps, nothing changes. Status asthmaticus is a dire medical emergency where the chest will be maximally hyperinflated. Right? Breath sounds and wheezes may be entirely inaudible. That means that their body is shutting down because of the air movement is negligible. There's nothing there anymore, right? The patients will also usually be exhausted, severely acidotic, and dehydrated. So aggressive airway management, oxygen administration, and prompt transport are essential, and you really should consider paramedic backup for anybody in status asthmaticus. For anaphylactic reaction, remove the offending agent. So whether it be a sting of some sort or other, get the agent off of them. Maintain airway. We're going to administer supplemental oxygen. Assist the breathing. And then epinephrine is the treatment for choice. 0.3 for adults, 0.15 for pediatrics. It's going to be administered in the right or left lateral thigh. For spontaneous pneumo, management of ABCs, provide airway and ventilatory support, and look for signs for tension pneumothorax. Consider IV initiation if severe symptoms are present. If they have a pneumo, get an IV in place. Place the patient in a position of comfort. A lot of times they'll be sitting up. We're going to transport and call for a paramedic unit if patient shows signs of developing tension pneumo where chest decompression needs to be completed. All right. Pleural effusion treatment is removal of fluid. Can't do it. Right? On the back of the ambulance. These patients need to get to a hospital. So what we're going to do is provide support measures and provide O2. As far as the pulmonary embolus goes, we're going to manage the airway, provide high flow oxygen, and assist ventilations as needed. Right? I've had this happen quite a few times where we've been transporting as fast as we can get there, and the patient goes into cardiac arrest. So initiate CPR for pulseless and apneic patients. IV fluids of isotonic crystalloid solution, that'd be like our normal saline, and then any other intervention you think would work that are supportive in what you're trying to do. Manage most severe cases as cardiac arrest of unknown origin, right? Transport and offer reassurance and call for a paramedic backup if needed. Unless they go into cardiac arrest, there's not much anybody's going to do other than getting them to a hospital where they can start the thrombolytic therapy. As far as hyperventilation, or this can be caused by a life-threatening illness or a panic attack. You don't know. You got to do more of an assessment. So give oxygen, transport, provide psychological support for anxiety-related hyperventilation. Interventions, pharmacologic interventions are rarely required. However, if they're hyperventilating due to sepsis, then we're going to have to give them medicine. Right? They're going to need medications to help support. Fluids, and then pressors as paramedics get on board, potentially. Have the patient mimic your respiratory rate and volume as well, and never place a paper bag over the patient's mouth and nose. That was back in the day. Found that didn't work. Patients were passing out. We got to stay away from all that. As far as obstruction of the airway, if there's an obstruction, we got to remove it. Right? So abdominal thrust, remove the obstruction. If the patient can talk and breathe, provide a supplemental oxygen, position of comfort for transport. And we're going to remove the obstruction by basic life support guidelines. Right? This should be nothing new to any of you on that aspect of it. However, if the patient goes unresponsive, obviously we start CPR and we continue. Have paramedics en route. We carry something called McGill forceps, where we can use a laryngoscope blade and go into the airway deeper than what you can see doing abdominal thrusts and doing a finger sweep if you can see it. We can see deeper into the airway to be able to pull stuff out. Okay? So have paramedics come on board, especially if they go unconscious. As far as environmental and industrial exposures go, industrial sites often have their own medical, fire, hazardous materials teams. And those teams are usually trained in the specific materials that are currently at that site. So they are going to be a wealth of knowledge and a resource for you to utilize them. So after the patient is decontaminated, gather the information on the substance and the cause of dyspnea. We do not take contaminated patients in the back of our ambulances. It's a hazmat scene. We don't even play in the warm zone. Okay, we stay in the cold zone waiting for fire or should the hazmat team to bring us a patient who's been deconned appropriately. The last thing we want is to toss someone in the back of our ambulance, right? That will expose us and the hospital. So they need to be deconned first. Blood coming from the airway is an ominous sign. Okay, suction the airway and provide 100% supplemental oxygen and assist ventilations as needed as long as the airway is clear. If the upper airway is compromised, aggressive airway management may be required. And also don't forget about having ALS support. Bronchiolitis. Treatment is entirely supported for this. So patient position of comfort, provide supplemental O2, assist with the BVM as needed, paramedic backup for endotracheal intubation if needed. Again, if they're doing okay and they're stable, get them to the hospital. RSV, look for signs of dehydration. Rehydrate the patient as needed, getting IVs in place. That means if you got to do a line on a 1-year-old, then you do it. All right. Don't withhold it because you're being uncomfortable. Look for a site. All right. And I'll make sure that the instructor on Sunday will go over that with you. Looking for different sites on pediatrics as well. Treat the airway and breathing problems as appropriate, and humidified oxygen is helpful if you have it. Like I said, not every service carries it. Croup responds very well to humidified oxygen. Okay, allows the patient to assume position of comfort, and don't agitate the patient at all. They'll just irritate the condition that they currently have. And if you have the ability to give nebulized epinephrine or racemic epi, then you can give it. I can tell you that New Hampshire and Maine and Massachusetts do not have that for that level. Paramedics still. Epiglottitis. Treat children of epiglottitis gently. Please do not do anything to make them cry. Right? The more irritated the airway gets, the more the increase in swelling will actually happen, causing potential for complete blockage of the airway. High flow oxygen, even by blow-by, is perfectly fine. Do not do anything with the patient's mouth. Nothing goes inside. And for the adult patient, focus on maintaining patent airway. As far as pneumonia goes, again, ABCs, high flow O2, ventilatory support is needed. CPAP if you need it. IV fluids may help the patient, but if a high fever is present, then you want to cool them down, so give them some fluids. And then also look for signs and symptoms of sepsis. As far as pertussis, some infants and younger children should be treated in the hospital. They are at greater risk for complications like pneumonia. So, and also can be sometimes very life-threatening. So children may vomit or not want to eat or drink. So watch for signs of dehydration. You've got to look for that. Suction as needed, oxygen therapy, And in adults or geriatrics, it does not typically cause whooping illness as seen in the younger children, but can cause a severe upper respiratory infection in older patients. That can result in pneumonia. So, and also on top of that, the significant coughing and the chronic coughing can also lead to having the ribs being cracked as well. That just causes more pain, shallow respirations, and the potential to make the pneumonia even worse. This is easily preventative with a vaccine, so AEMTs should check their immunization status and get a booster as needed. Right, so know what your vaccination statuses are. You need to anyways for the clinical rotation. So as far as airway obstruction goes, perform the appropriate airway clearing technique. Provide transport. As far as heart failure goes, consider CPAP. Right? Consider CPAP with this. High blood pressure and low cardiac output often triggers this flash sudden pulmonary edema. So in addition to the classic signs of respiratory distress, they may have the pink frothy sputum coming from the mouth. Now we have blood back up into the lungs. The patient's pulse will be tachycardic, and the patient may have hypertension early, so followed by deterioration. Hypotension is a late finding. Patients that have heart failure and pulmonary edema really need nitrates if they're hypertensive, and CPAP to push the fluid out of the lungs. The nitrates are going to vasodilate, which will lower the blood pressure. A lot of times what you'll find in a patient with heart failure will have a blood pressure like 200 over like 110. So usually they're pretty hypertensive, right? But sometimes, again, they can be hypotensive for a late sign. So you may get them at that stage of their exacerbation of the acute pulmonary edema. Any kind of tracheostomy dysfunction, children with a chronic pulmonary medical conditions may have a home ventilator connected to a trach tube. Complications include obstructions, bleeding, leaking, dislodgement, or infection at the area of the trach. So you're going to establish a patent airway, place the patient in a position of comfort, and suction to clear the obstruction. If the patient is on their own ventilator and they're ventilating fine, as an EMT and an AEMT, you can take that on a 911 call, okay? As long as you have the mom or dad or the caregiver in the back of the ambulance with you. Right, almost there. So if unable to clear the airway, consider paramedic interventions, all right? After the obstruction is clear, oxygenate and treat. So geriatrics that may have a trach tube in place because of airway obstruction, laryngeal cancer, severe infection, trauma, or the inability to manage secretions. This can be obstructed by secretions, foreign bodies, or swelling, or a stoma itself can become infected. So establishing airway patency is the immediate goal. So again, if you haven't dealt with a patient with a stoma, they really can have a lot of secretions built in that hole. You may just have to suction at the beginning to kind of clear up that mucus plug. All right, so epidemic and pandemic considerations, obviously looking at flu and COVID-19. I don't think I really need to hit this as hard. We've been dealing with this for the last couple of years. Protect yourself. Wear the appropriate PPE. HEPA respirators, all right, during any aerosolized generating procedures, right? We shouldn't be wearing regular surgical masks for COVID right now anyways. We should be still wearing our N95s and those whenever you're going to be utilizing. But stay up to date on the latest CDC recommendations, okay? They're keeping track of everything. Appropriate PPE. As far as COVID-19 goes, which is a new coronavirus, like we all know, SARS-CoV-2, it's spread through droplets. Symptoms appear 2 to 14 days after exposure. And same thing as the flu. Fever, chills, cough, sore throat, dyspnea, fatigue, congestion, headache, muscle or body aches, loss of taste or smell, nausea, vomiting, diarrhea. All right. Again, emergency warning signs include dyspnea, chest pain, confusion, cyanosis. If patients have these, they need to go to the hospital if they have COVID. If they're alert oriented with SATs in the 90s and just don't feel well, right? We still have state protocols we have to follow, contact med control, and they probably do not need to go to an ER. Okay. Advise them to drink fluids. Pedialyte works really well. Stay hydrated, electrolytes, things like that. But if they have any confusion, chest pain, cyanosis, respiratory distress, dyspnea, these patients need to go to the ER for further evaluation. Wash hands often. Avoid touching your eyes, nose, mouth. Cover your cough or sneeze. If you're sick, stay home. Wear a mask. Almost done. Follow the guidelines, 6 feet, the whole deal. All right. We already know all about this kind of stuff. I'm going to go through it all. N95s, eye protection, disposable patient examine gloves, disposable gowns as well. And then, as you can see, donning and doffing procedures. All right. So have the patient also wear a face mask. If they say they don't feel comfortable, well, it's too bad for them. All right, we got to protect ourselves as well. Put a face mask on them. You can still run end tidal monitoring with these patients, even with a face mask over the patient's face. They'll still get accurate readings. All right, and follow local protocols. Does anybody have any questions on respiratory? Any questions at all? All right. Did I hit what you were looking for in this? Again, if you guys have any questions, let me know. I'm more than happy to go over anything with you guys one-on-one, by phone, or whatever. Awesome. On that note, this kind of covers some things before we let go. Right, class on Sunday starts at 9. You have a guest instructor that day. Please be on your best behavior. All right. She is a wealth of knowledge, especially when it comes to IV therapy. With her background in phlebotomy, she can definitely help us all out. The quiz will be up and running for 10 o'clock tonight. It is good for 1 week. For those of you that need to take the exam, I think I have it open until midnight tonight. So if you haven't done it yet, the retake, go back in and take care of that as soon as you can. And I believe all the other quizzes are still currently open. So if you have low grades, go back and change them. All right, go back and take the quiz again. Let's see what else we have going on. We have class next week, Wednesday and Friday. I have a guest instructor next Friday, as I will be at an EMS conference. Paramedic will be covering neurologic emergencies. I'm sure she will do well. Please be on your best behavior. And that's about it. Please make sure you guys are sending me your clinical rotation stuff. I also need to make sure I have all your records. So remember, you have to show me proof of your HPSO insurance in order to start clinical rotations as well, along with your vaccine records and all that. And I'm not talking just about COVID, other stuff too. The forms I gave you on your first night. If you do not have the forms, please let me know.